Hello, my name is Jaideep Kapoor, and welcome to the Small Islands Epilepsy Conference. This epilepsy conference is organized by International League Against Epilepsy and its North America Commission. This is an effort to bridge and reduce the treatment gap in epilepsy in collaboration with the World Health Organization. International League Against Epilepsy has come up with an ambitious plan to reduce the burden of epilepsy across the world. We want to make sure that individuals with epilepsy get diagnosed, get appropriate treatment, and as many as 70% of them become seizure-free. This is a highly ambitious goal, and we have set a bench of benchmarks. We've set a set of benchmarks to achieve those goals. One of the key goals is to educate physicians, primary care physicians, care providers, physician extenders, community health workers, primary care neurologists in epilepsy, so that access to epilepsy care can be expanded. And today's meeting is an effort to reach all of you across the world. We made this a web-based meeting because it is much easier to access populations across the globe via the internet than in person. Today we have an exciting set of speakers, some of the great leaders in epilepsy who have volunteered their time and effort to talk about fundamentals of epilepsy, which would be valuable to all. I have the great pleasure of starting with one of the global leaders in epilepsy movement and epilepsy research, Dr. Sam Wiebe, who's a professor of neurology at University of Calgary and Associate Dean for Clinical Research there in Canada. Professor Wiebe has been the president of International League Against Epilepsy and is the current past president of the International League. He's done seminal research in many, many areas of epilepsy research. And in addition, he's been an inspirational force in organizing our effort to achieve this goal of reducing treatment gap and putting it across the globe. Dr. Wiebe has done seminal work on epilepsy surgery and showing that epilepsy surgery can be effective, much more effective than drug treatments. But beyond that, Dr. Wiebe has really emphasized global collaborations and people across continents, countries working together to address the challenges of epilepsy. So let me start by welcoming Dr. Sam Wiebe.
Hello, everyone. In the next few minutes, we will be exploring together in a brief manner the classifications of seizures and epilepsy during this web conference of the small islands of ILAE, North America, and Asia, Oceania. These are my disclosures and the objective for the brief presentation today. The ILAE classifications have a very long tradition, starting perhaps with Gastaut and the proposed international classification of seizures of 1964 and culminating with the most recent definition of syndromes, which has just been published in the last few months. Why are classifications and definitions important? Well, as far as the International League Against Epilepsy is concerned, it is mostly for the purpose of clear communication. And this is based on the most recent evidence. It should be widely applicable, and it should be practical and for clinical purposes primarily. Let's start with some seizure definition. A seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. An acute symptomatic seizure has a close temporal relation with a brain insult of various causes. A remote symptomatic seizure, on the other hand, is that which occurs after the insult has been resolved, often about 7 days after the insult is resolved. And then an unprovoked seizure has no apparent cause and has no preceding history of brain insult or other abnormalities. The definition of epilepsy is, as I said earlier, an operational definition. It can be arrived at by two ways. You can have epilepsy, you have two unprovoked seizures more than 24 hours apart, or if you have one unprovoked seizure plus a risk of recurrence of at least 60%, or reflex epilepsy, or an epilepsy syndrome. You also have a new term, which is epilepsy that is resolved. And epilepsy is said to be resolved when the person is seizure-free if the person has an age-dependent epilepsy syndrome and the age is past for that applicable syndrome. Or you can be seizure-free for at least 10 years without anti-seizure medications for the last 5 years. So this is a classification of seizure types. Very straightforward, very simple. 3 general types: focal seizures, generalized seizures, or unknown seizures if we don't know what the onset of the seizure is. We will review in a moment what the basic rules are for classifying seizures. Keep in mind that at all points in time, we need to remember the etiology as an important aspect of the seizure classification. For example, you can have seizures that are of structural, genetic, infectious, metabolic, immune origin, or unknown. Seizure types then give rise to the classification of epilepsy using exactly the same terminology, and then you can move on to epilepsy syndromes if you have enough information. And all along, we keep in mind the comorbidities that are associated with these different types of seizures, epilepsy, and syndromes. So, for example, the ILAE classification of seizures has within the 3 broad categories of focal, generalized, and unknown onset. In the focal onset, either aware or impaired awareness seizures, and you can also classify them based on motor or non-motor features. It is an alternative. Most people and most of us focus on the classification of aware or impaired awareness focal onset seizures. And then there is another element, which is a focal to bilateral tonic-clonic seizure, and those are the ones that start focally and then become widely involved in both hemispheres. For generalized onset seizures, you have 2 main types: motor types with all the features that you see underneath here, and then absence or non-motor types, and these are the types of absences. And then you have those seizures in which you do not know what the onset is, and they could be motor or non-motor. And then there are those that are unclassified, and that means that you have inadequate information or inability to place the seizures in other categories. So once you have the main seizure types, which are focal, generalized, or unknown, you can then think about etiology. But persons or people with epilepsy can have more than one etiology. Tuberous sclerosis happens to fall into 2 categories: structural, with the tubers and other abnormalities of the brain, and also genetic, because it is genetically determined. For example, GLUT1 deficiency also has more than one etiological category, and it is genetic because it is genetically determined, but it is also a metabolic type of epilepsy. So once you know the seizure type, we need to think about the clinical descriptors that go along with those seizures, and these are some of those that we use more often. For example, atonic focal seizures, seizures with automatisms, autonomic, clonic, cognitive, emotional, hyperkinetic instead of hypermotor, etc. There are general rules for classifying seizures. Probably the most important one is that the onset is the most important thing. The seizure should be classified according to the earliest and most prominent feature. And then you need to decide if it's focal or generalized with about 80% confidence. Otherwise, you call it unknown. Impaired awareness can occur at any point during the seizure, And you can use motor or awareness as the main classifier. Behavior arrest, on the other hand, must be a prominent feature throughout the duration of the seizure. And then, as I said earlier, you should add additional descriptors as listed above. And then bilateral versus generalized. A bilateral tonic-clonic seizure is the one that propagates from an initial focal seizure. And the generalized seizure is that which is bilateral hemispherical from onset. Once you know the seizure type, this determines the type of epilepsy with the same terminology. Just like seizures, epilepsies can also be focal or generalized or unknown, but you also have this category of combined generalized and focal. Some examples are here. Focal type of epilepsy is, for example, temporal lobe epilepsy. Generalized is a young child with generalized tonic-clonic seizures and generalized spike wave in the EEG. And unknown if you cannot tell which one of these two it is. And then this category of combined generalized and focal is a patient that may have both focal seizures and generalized seizures. For example, a person with absence epilepsy who then undergoes a brain lesion that produces a focally originating seizure in addition to the generalized. It is important to remember that after being absent for some time, idiopathic generalized epilepsies are back officially, and these are the four main types of idiopathic generalized epilepsies: childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and generalized tonic-clonic seizures alone. The term benign, as in benign epilepsies, has been abandoned in recent classifications for two main reasons. One is that many epilepsies that are called benign are really not benign. For example, childhood absence epilepsy can have important psychosocial comorbidity. Also, for example, benign epilepsy with centrotemporal spikes can have learning concerns. And the other reason is that there are two adequate terms that can be used for these benign epilepsies. One is self-limited, and the other one is pharmacoresponsive. In most instances, we will use self-limited instead of benign. The other term that has been replaced largely is that of symptomatic generalized epilepsies. Why? Because even though it is beloved and many people use it, and we've used it for many years, it is problematic because everything is symptomatic of something else. It entails brain dysfunction, usually cognitive dysfunction, and it is used for different groups of disorders. So instead of that, the new terms is epilepsy with encephalopathy. And these are of two main types. One is epilepsy with developmental encephalopathy, in which case the developmental delay with seizures is infrequent enough to cause regression or slowing of development. And the other type is epileptic encephalopathy, in which there is no pre-existing developmental delay, and the cause of epilepsy is insufficient to cause the epileptic encephalopathy, and the epileptic activity contributes directly to the developmental delay. Two important resources I would like to point out to finalize this brief review of definitions and classifications is the recently published paper on seizure semiology by the ILAE, which contains a large catalog of semiology based on video extracted features with video links where you can actually see features. And the second one is the diagnostic manual of the ILAE, which has the entire classification divided by, for example, by etiology, or divided by type of seizure, by age, etc. And this is one example of you will find. It has some video links with it. It has some genetic features, structural abnormalities, etc. And with this, I would like to thank you for your attention.
Thank you so much, Dr. Veep, for that excellent talk. We have more than 80 participants, listeners, and I'm sure you have many, many questions. Please put them in the chat box, and we will address your questions just after the next talk. And our next speaker is Dr. Dang Nguyen. He has obtained his MD and PhD and neurology degrees at University of Montreal and completed his epilepsy fellowship training at Yale University. For the last 23 years, he has been caring for patients with complex epilepsy at Montreal University Hospital Center. He's also a principal scientist at the Montreal University Hospital Center Research Center full professor in Department of Neurosciences at the University of Montreal, and holds a Canada Research Chair in Epilepsy. He is a past president of Canadian League Against Epilepsy and is currently on the executive board of North American Commission of International League Against Epilepsy. Welcome.
In this recorded presentation, we will discuss about a few paroxysmal events which can mimic seizures. I have nothing relevant to disclose. Seizures can broadly be divided into epileptic or non-epileptic. Non-epileptic seizures themselves can be subdivided into physiologic or psychogenic. Non-epileptic events of physiological origin include, for example, transient ischemic attacks, paroxysmal movement disorders, paroxysmal endocrine disturbances, syncopes, and sleep disorders. Because we only have 15 minutes, I will focus only on events seen in adult patients. A common reason for consulting a neurologist is to distinguish a seizure from a syncope. Most of the time, it's quite easy with a characteristic prodrome, typical precipitants, unless of course it's due to a cardiac arrhythmia, skin pallor, and minimal to no postictal confusion. Remember that it's not rare for patients to exhibit abnormal movements after losing consciousness. Lampert and colleagues studied 42 patients with syncope induced by hyperventilation, orthostasis, and Valsalva, as seen here in the video. 90% of them had multifocal or generalized myoclonus after losing consciousness. 80% had some head movements, oral automatisms, or writing movements, and 60% of them reported visual and auditory hallucinations. Typically, the multifocal or generalized myoclonus are of short duration, less than 20 seconds. In general, it's relatively easy to distinguish transient ischemic attacks from seizures, since in TIAs, patients will complain of a deficit rather than positive symptomatology. There are some exceptions, of course. Patients who have seizures starting in language areas will not talk more, but be aphasic. There are also rare cases of patients with focal parietal seizures associated with ictal asomatonosia, which can cause falls. Patients with severe carotid stenosis and low blood pressure can have hemodynamic TIAs when they stand up. Here's a patient who was asked to stand up. Notice how he will develop brief arrhythmic jerking movements of the arm and leg when there is regional hyperperfusion, documented here by near-infrared spectroscopy. Patients who have low blood sugar can have mild neuroglycopenic spells or even acute convulsions, depending on the severity of the hypoglycemia. The diagnosis is easily made when a patient is known to be diabetic and taking medication to lower blood sugar. However, when a patient is not diabetic, it can take several months and years before we can make the diagnosis of neuroglycopenic episodes due to Munchausen syndrome, for example, or insulininomas. Insulininomas are benign solitary pancreatic adenomas, which will secrete excessive amounts of insulin at inappropriate times, leading to paroxysmal neuroglycopenic episodes. Here's a patient who was falsely diagnosed with atypical epilepsy, who had recurrent confusional spells for 7 months before the right diagnosis was made. In between episodes, her blood sugar levels were normal. You can see how she exhibits abnormal posturing, sometimes catatonia, and sometimes body movement. Sleep-related disorders are a complex chapter, and we won't have time to go into details. Sleep-related epilepsy and non-epileptic sleep-related phenomena can share similar manifestations. Diagnosis requires extracting semiology and clinical features by questioning the bed partner and doing a polysomnographic study with both video and EEG. Periodic limb movements and disorders of arousal, such as sleepwalking, night terrors, confusional arousals, tend to occur in the first half of the night, while nightmares and REM sleep behavior disorders tend to occur in the second half of the night. Here's a patient with REM sleep behavior disorder. And here's a patient with nocturnal terror. The patient thought she had snakes around her neck, but it was actually EEG electrode wires. Movement disorders mimicking epilepsy is also a large chapter to cover. Here's a brief list of events. Shuddering attacks, myoclonus, either benign or secondary, paroxysmal dystonias, kinesiogenic, non-kinesiogenic, or exertion-induced, tics, tremors, stereotypies, oculogyric crisis, hemifacial spasms. Of course, one important clue is that movement disorders are not associated with altered consciousness, and EEG is normal.
Look at me, show me your eyes. This time, I just need to try. I want to video it, Jake. Look at me.
So that was a patient in an oculogyric crisis.
Exercise triggers a brief episode of hemidystonia.
Don't bend over. Don't bend over.
So that was an example of a kinesiogenic paroxysmal dystonia. And here's an example of hemifacial spasm.
I have hemifacial spasm.
Okay. How long has this been going on?
About 2 years.
Okay. And how long have you had this?
It's about 5 years.
Okay. And
Finally, but not least, functional seizures are, in my experience, what fools physicians the most. Keep in mind the rule of twos. If a patient has at least 2 normal EEG studies, more than 2 seizures per week, and has already failed 2 anti-seizure medications, then the predictive value for psychogenic non-epileptic seizures is 85%. There is no single clue to diagnose a functional seizure. Some useful hints include eyes that are closed during a seizure, if the patient provides resistance to eye opening, if the patient avoids harm during a seizure, if they occur only when the patient is awake, or if the seizures are induced by suggestion. Suspicious movements include hip movements, migratory movements, opistotonic posturing, when movements stop and go, and when you can modify the seizure process. Patients may bite their lips or the tip of their tongue, but there will classically be no tongue laceration. Here's an example. So this patient was a prisoner. You can notice the handcuffs. He was trying to fake a seizure in order to get out of prison. In summary, there are many things that can mimic seizures. The only way to get better at this is through continuing medical education and seeing a lot of videos. Don't forget you have a powerful tool in your pocket, and that's your mobile phone. If in doubt, send me or other experts in the community if you're not sure of the diagnosis. We have a few minutes left, so I've prepared a video quiz for you. In this quiz, you must decide if the patient has real epileptic seizures or functional seizures. I'll provide you with the right answer as we look at them. Because we only have a few minutes, I will only show you important segments of the seizure and not the whole seizure itself. So this was a real seizure with tonic posturing, the figure of 4 posturing. So this patient had non-epileptic seizures. Notice the tone was not increased. This patient had a real epileptic seizure with limb automatisms and jump. This was a true epileptic seizure. The patient was laughing. It was a gelastic seizure. So this was an example of an absence seizure. But this was not an epileptic seizure. The patient was hyperventilating. So this was a real tonic seizure. This was a real left frontal lobe seizure with right eye deviation and head deviation and a twitching of the right side of the face. This was a non-epileptic seizure. Notice how you can modify the seizure process with menacing. This was a non-epileptic seizure. Notice the normal tone, and there's no tonic phase before the clock. This was non-epileptic. Notice the movements of the hips and the normal tone.
Yep.
It was a real left frontal lobe seizure with right head deviation, figure of 4, and that this was a non-epileptic seizure with eyes closed and abnormal movements of the left arm.
Yeah.
So that was a real seizure with tonic posturing. So we'll stop here, and I'm ready to take your questions.
Thank you so much, both of you, for your excellent talks. So I see that there are more than 100 participants in our session right now, live. I'm sure you have more than 100 questions, and we have plenty of time to answer your questions. The way you ask questions is put them in chat box Q&A, and I will read them out, and our panelists will answer them. So the first question is to Dr. Veeb. Thank you for an excellent talk. Would you like to share the recent definition of status epilepticus? Thank you.
Yes, thank you very much. Yes, and I would very much have liked to have included that in the presentation, but in 10 minutes, you can only say so much, right? So it's a very important question. Of course, status epilepticus is defined as a seizure that is prolonged because of failure of the mechanisms that normally occur in the brain to stop a seizure, or the mechanisms that produce a seizure and cause it to be long. And we usually use two time frames. We use time frame 1, or T1, as the time when, if the seizure lasts that long, it is very likely status epilepticus. You need to intervene and you need to treat. And there are different times for different seizure types. For example, for a bilateral tonic-clonic seizure or for a generalized tonic-clonic seizure, it's 5 minutes. So if the seizure goes on for 5 minutes, you can classify that as status epilepticus. For a seizure that is focal with impaired awareness, say a temporal lobe seizure, or what used to be called a psychomotor or a complex partial seizure, now called focal impaired awareness seizure, the time is 10 minutes. If the seizure goes on for 10 minutes nonstop, then you can call that status epilepticus. And finally, for seizures like absence seizures, it's about 10 to 15 minutes. So those are the current timeframes that we use in order to define whether a prolonged seizure is actually status epilepticus.
So I have a couple of management questions, and we can address them now, but I suspect there'll be other speakers who'll be addressing them, some of these questions in the future also. But let me begin with, what is your management of an infant who experiences seizures after vaccination? Should vaccinations be given again? Who wants to address that? And other panelists are here too. So anyone among the panelists who want to speak up, you're welcome to speak. I know that there are other people speaking later in this meeting here. So welcome, and you can join in as well on that question. Dr. Veeb, do you want to take the first stab at it?
Sure, for sure. I'm not a pediatric neurologist, but so as if a child has clearly a seizure associated with a vaccination, there are things you can do, of course, in order to prevent that from happening in the future. You can pre-medicate the child with, for example, medication to avoid a seizure or prevent a seizure. I would be very cautious to say that a child should not receive further vaccinations because of a seizure happened, right? I mean, there are, of course, rare instances where an encephalopathy may develop an association because of a number of reasons, but for the most part, these are reactive seizures or acute symptomatic seizures, and they can be prevented and treated I don't know if any other panelists have other opinions.
Hi, can you hear me?
Yes, we can hear you, Bill.
Yeah,
Dr. William Theodore from NINDS.
Right. So I'm not a child neurologist either, but there have been some genetic syndromes. Some of the mitochondrial disorders have been associated particularly with seizures after some vaccinations. So if genetic testing is available, that's not a bad idea. The other thing is that not all vaccinations are the same. So, you know, some vaccinations might be perfectly safe in that kind of situation, whereas others might be more risky. So that would be something that I think an expert in virology might be consulted about.
I'll just throw in my 2 cents. I agree with what has been said. It may be related to the history of MMR potentially causing seizures in the past. That was debunked because of the data. But I totally agree with Sam. Vaccinations should not be stopped. There's a specific syndrome called Dravet syndrome, in which seizures may break through post-vaccination, but it's not a cause and effect. Thanks.
There is another question on treatment, which I'm going to skip, but go to the next one. How do you test tone and no normal tone in non-epileptic seizures? That's for Dr. DeGuin.
Yeah, what I meant was just by observation, you can differentiate an epileptic seizure from a non-epileptic seizure. Typically, the most common presentation of a non-epileptic seizure is the convulsive type. So patients have tremors of all 4 limbs. Typically, patients don't have a tonic phase first. They just go straight to the clonic phase. So they just start having tremors. So it's typically you won't have that initial tonic phase. So that's one clue. And when they have the tremors, when they shake their limbs, typically the limbs are not stiffened. They're normal tone or hypotonic, and so then they have flailing movement. So that's what I meant by normal or normal tone. In real epileptic seizures, when they have tonic-clonic seizures, when they're in the clonic phase, their limbs are stiffened, and so that's what I meant by normal tone or versus increased tone.
So next question is, how do you differentiate hyperkinetic seizure from a nightmare attack?
Yeah, so hyperkinetic seizures, in every situation, of course, you always have to have a good questionnaire, so a good clinical history with age, past medical history, family history, medication, etc. Everything is a clue in itself into making your final diagnosis. Now, looking at the seizures themselves, the behaviors encountered in hyperkinetic seizures and in sleep disorders, you can have the whole spectrum in both conditions. And so just on the basis of semiology, it can be difficult. Now, of course, in hyperkinetic seizures, one thing is most patients with sleep hypermotor epilepsy, it's rare that they have 100% of their seizures at night. Most of the time, it's like 90% sleep related, and they can have 10% of their seizures during daytime. So that's one clue, of course. Then you have the family history, you have the MRI, you have the EEG. EEG, you have to be careful because, of course, in hyperkinetic seizures, you can have a lot of muscle artifacts, so that it can be difficult. But one good thing is in hypermotor seizures, because the seizure starts during the night, the first part of the EEG, the first 1 or 2 seconds, is relatively artifact free. So sometimes you can see the initial epileptic discharge, and so that helps you a lot. I don't know if there's the other people want to add anything.
Other panelists? If not, I have a question. How do you diagnose atypical absence seizures?
Well, atypical absence seizure, I'm not a pediatric neurologist, but typically atypical absence seizures, the child or the patient has some sort of intellectual deficiency, developmental delay. The EEG, the background EEG is not normal. It's a little bit slow. The spike and wave discharges are not the typical 3 Hz spike and wave discharges, and so those are clues to identify atypical absence seizures.
I would.
This is a question. Go ahead.
Yeah, I would briefly add that. Completely agree with that. Those features, the atypical absence are typically more gradual in onset and termination than the typical absence, right? The typical absence is you turn a switch on or off, bang, bang. It's on, it's off, right? An atypical absence is a gradual onset and a gradual termination, and people can actually have a prolonged absence. They're typically longer lasting, and they can also have complex things like manual automatisms. In fact, the difficult distinction there is between an atypical absence and a focal impaired awareness seizure, which can also have very similar things. And as Dan mentioned, the EEG will clinch the diagnosis as the most important aspect.
Any other panelists? Otherwise, I can go on to some management questions here. So, and this is open to all panelists. I wonder how long would you keep a patient with symptomatic seizures on anti-epileptic medication, which now we are beginning to call anti-seizure medication?
So symptomatic seizure means acute symptomatic seizures. Yeah, I think that's what is meant, right? So acute symptomatic seizures typically occur within the acute period, the acute insult to the brain, right? So once the insult is resolved, then you typically do not need further anti-seizure medication. So the typical duration is about 7 days. This is for things like a stroke or an injury, a brain injury, and things like that, right? So now, on the other hand, if seizures begin to occur after that period of time, then we really are talking about remote symptomatic seizures, which have a much higher risk of resulting in a persistent trend to have seizures and therefore an epilepsy. And then you're looking at long-term treatment. But acute symptomatic seizures with an acute event, you treat only during the acute event, and that's it. And I think it's also important to distinguish those from seizures that are related to acute disturbances such as metabolic disturbances or alcohol withdrawal seizures or hyponatremia. In those situations, we treat the underlying condition and only give things like benzodiazepines acutely to control the seizures. But the key there is to treat the underlying acute disturbance that is producing that, whether it's hypoglycemia, hypercalcemia, hyponatremia, et cetera, et cetera. Those we do not treat with anti-seizure medications.
Yeah, if I may add, the duration is not fixed. It depends on the clinical situation and the context. Typically, we say 1 week, but that's based on epidemiological data where most of the acute seizures occur at home when the acute event occurs, or within the first 24 hours, and after that, 48 hours, 72 hours, the chances of having an acute seizure drops dramatically, so that at the end of 1 week, the chances of having an acute seizure is really low. However, you know, I think it's okay if the patient has, for example, acute brain hemorrhage with edema, and you don't feel comfortable withdrawing the anti-seizure medication. If you want to keep it 2 weeks, 3 weeks until he's out of the major acute phase, it's fine as well, as long as you don't keep it for 3, 4, 5 years. So the message is, think about eventually stopping it when the patient is out of the acute phase. So it's the same thing. If you have an acute herpetic encephalitis with seizures, you can keep it longer because you don't feel he's out of the blue yet. So you don't need to keep at exactly 1 week and withdraw the medication. You can judge by yourself. It's just, the message is just not to keep it forever.
I think we have time for at least one more question. Can you report the conclusion of psychogenic non-epileptic spell or other types of seizures in an EEG result? I know several people on the panel can answer that, but Dang, you can take a stab at it first.
On the EEG report?
Yes.
Yes. So most centers now, when they do a routine EEG, the machine has the capability of doing the video recording as well. So it's not in video EEG monitoring unit anymore. Even in routine EEG labs, you have the camera with the EEG. And if the patient has an episode at that moment, and you don't have any epileptiform activity associated with the event, then I don't see any problem with diagnosing that the episode was not associated with an ictal discharge. Now you have to be careful. You have to look at everything. Now, if the event was minor, for example, if the patient had a sensory symptom, which could be an aura, for example, well, you have to know, of course, that auras or simple focal seizures without impaired awareness of short duration cannot have any obvious EEG changes on surface EEG. So you have to make the electroclinical correlation. Now, if it's a big, quote unquote, convulsive episode for 30 seconds and you don't have any ictal change, then of course you could conclude. Now, does the patient has concomitant epilepsy as well? That's another question. Of course, it can happen. In studies, it can go, it's approximately 15%. It varies from studies to studies, but it's about 15% of patients who have non-epileptic seizures who also have epilepsy. And so you have to be careful about these patients. But most of the time, when a patient has non-epileptic seizure, there's more chance of him having only non-epileptic seizures than also have concomitant epilepsy.
Thank you. Thank you so much, Danga. And I think some of these questions will be addressed in our next talk. So I want to thank both Dr. Nguyen and Dr. Weeb for excellent talks. And I think that a question answer session, which has been very interesting and educational. The next talk is by Dr. William Theodore. He will talk about EEG correlates of epilepsy. Dr. Theodore is the chief of clinical epilepsy section at National Institute of Neurological Disorders and Stroke, which is a part of NIH in US. He's also the vice president of American Epilepsy Society. He received his BA degree from Harvard College, MD from Columbia University College of Physicians and Surgeons. He did his neurology residency at Mount Sinai School of Medicine, and he came to NIH for his fellowship in epilepsy and clinical neurophysiology and has stayed ever since. He's made major contributions to our understanding of new anticonvulsants and anticonvulsant mechanisms, cerebral metabolism, functional cognitive anatomy, neuroimaging of epilepsy, an absolute leader in epilepsy research. Welcome.
I'm going to talk about the role of outpatient EEG in the evaluation of patients with epilepsy. So the first question to ask is, why do a routine outpatient EEG? The main objective is to provide supporting evidence for a clinical diagnosis of a seizure disorder. And you can also try to help specify an epilepsy syndrome, help localize a seizure focus, possibly detect ictal episodes. You can use it to assess anti-seizure medicine effect in some genetic generalized epilepsies, although not for most focal epilepsies, and perhaps help assess the risk of anti-seizure medicine withdrawal in seizure-free patients. Of course, EEG can be used to help investigate other brain disorders, patients with altered behavior or mental status, but we're of course going to concentrate on epilepsy in this session. So it's important to know as much as you can about the patient, including their age, which obviously is going to help you assess the PDR, the history, the neurologic examination, their cognitive and sleep-wake state, any medications that they might be on, if they have a skull defect or a space-occupying lesion, or a history of head injury can also affect the EEG even if imaging is normal. And of course, metal implants can cause artifacts. Obviously, you can see big background differences between children and adults, and of course, you need to take these into account. So the American Clinical Neurophysiology Society has a set of EEG recording guidelines, and it's very helpful to follow these in order to get technically good recordings, and particularly to ensure that one recording can be compared to a subsequent recording, or recordings can be compared across EEG laboratories. One of the main points that they make is only use filters if really needed. And you can see an example of that here, where changing the filters from 70 to 15 hertz has transformed muscle activity into focal interictal epileptiform discharges. So it's important to be aware of the normal features of the EEG, and particularly the differences between wakefulness and various states of sleep. And in children in particular, the sleep state changes can be associated with dramatic EEG manifestations, such as hypnagogic hypersynchrony, which are perfectly normal but can sometimes appear rather disconcerting. The ACNS has also come up with some definitions of various interictal epileptiform discharges, such as spike, spike and wave, polyspike, and sharp wave patterns. And again, it's very useful to adhere to these in order to allow comparison from one record to another, particularly when you are following a patient over time. So now I'm going to show you just some examples of some epileptiform discharges, and then go over some of the benign variants which can appear on EEG recordings and occasionally cause confusion. So here are some left occipitotemporal epileptiform discharges. So here you have a nice spike with a ongoing slow wave. And here you have some bilateral independent centrotemporal discharges. And some frontal polyspikes. And here you can see how EEGs can differ from one recording to another. So here's a patient with a left frontotemporal focal cortical dysplasia, and on one record, the patient just had focal slow activity, and another frequent repetitive epileptiform discharges. So again, underlying the importance of doing multiple records in a patient suspected to have epilepsy. Okay. Seizure onset can also vary if you happen to record a seizure from one EEG to another. Here you have, again, in the same, not the patient as before, but a different patient, two recordings, one showing a left temporal seizure onset and another showing a right temporal seizure onset. So if you're doing an evaluation of a patient for whom you're considering the possibility of epilepsy surgery, it's obviously very important to do serial records or, if possible, to do video EEG monitoring. It's particularly important to do this if the patient's clinical seizure manifestations have any differences, because that could be a hint that there are seizures arising from different brain regions. You can also have sharp transients and spikes, but no seizures. So here's a child with sialidosis, and you can see sharp and slow wave discharges here. This is fairly common in children with autism, for example, and some patients like this can be conceived to progress to having seizures, but this is by no means always the case. So it's very important, particularly when you're writing reports for referring physicians, to stress that epileptiform discharges by themselves, again with the exception of some of the genetic generalized epilepsies, are not a criterion for anti-seizure medicine treatment. Only clinical seizures are. You can also see epileptiform discharges in highly screened, typically developing children without any neurologic deficits, who have also been followed for several years after the study and did not develop seizures. So in these two studies by Ike Olufsen, kids from 1 to 15 had about 2 or 3% epileptiform discharges, and even older young adults did as well. So it's very important to keep this in mind. So now let's talk about some of the benign variants, of which there is a fairly long list. And some of these have traditionally, particularly in the early era of EEG, been associated with so-called neurovegetative disorders, but are now considered to be normal variants. So the mu rhythm occurs in central regions and in relatively fast frequencies. It can be unilateral or bilateral. It can come and go. Like most of these, it's more evident during drowsiness, and it attenuates with movement or even contemplation of movement, which is rather interesting. So-called wicket spikes are a little bit faster in the alpha range. They tend to be mid-temporal, like many patterns associated with drowsiness. No aftergoing slow wave, and no particular association with any clinical patterns. This slide shows two versions of the so-called 6 Hz phantom spike and wave. The WAM, wake high amplitude anterior male pattern, which you can see here. This pattern is thought to be more likely to have potentially epileptogenic implications than the fold or female occipital low amplitude drowsy pattern. However, the evidence supporting clinical implications in the case of WAMs is not very strong, and these are also better regarded as a pattern of a normal variant. Okay, the 14 and 6 hertz positive discharges are often very difficult to pick up. So here you can see the 14 and the 6, and again, they can come and go, and they can be unilateral, they can be bilateral, first on one side, then on the other, and as most of them associated with drowsiness. Small sharp spikes appear in the temporal regions in drowsiness in young adults, and they look clearly different than true epileptiform discharges, which are more spiky and actually have an aftergoing slow wave, which these tend not to have. They have a broad field, they're not particularly focal, and again tend to occur during light sleep or drowsiness. The rhythmic mid-temporal discharge or psychomotor variant is a 5 to 7 hertz pattern, kind of a sawtooth wave that never evolves into anything and is not associated with any clinical activity. The Saganic rhythm is another one of the family of theta rhythms, this one tending to occur more in the midline in bursts lasting a few seconds, and occasionally can have a spiky appearance. The amplitude waxes and wanes, and as with the others, it tends to be most common in drowsiness, and it does not evolve in the manner consistent with an epileptiform discharge. The subclinical rhythmic electroencephalographic discharge of adults can go on for quite a long time. This, in contradistinction to some of the other patterns, tends to be more common in older adults as opposed to young adults, adolescents, and children. It can go on for several minutes at times in this 5 to 7 hertz pattern. It's usually bilateral, or else it can come and go from one side to the other. And it's not associated with any clinical symptoms, any alteration of awareness at all. This slide shows the initial onset of a focal dyscognitive seizure, most prominent in the left temporal derivations. And you can see the beginning of the 5 to 6 hertz activity, which is now rapidly evolving into a faster rhythm, and then it's going to become secondarily generalized. Okay, so in contradistinction to epileptiform discharges, the normal variants seem to come and go sporadically. They generally do not disrupt the background. They don't evolve into a different sort of pattern the way a seizure does. They generally have very little associated slow activity, and they have no clinical correlates. So how can you increase the yield of outpatient EEG? First of all, it's important to have a high pretest epilepsy diagnostic suspicion so that you can concentrate your evaluations on the patients who will benefit it the most. You can increase the length of the recording. So in one study, doing it from 30 to 60 minutes, which basically is like doing 2 EEGs, led to about a 20% increase in detection of interictal epileptiform discharges, and even a 16% increase in ictal patterns detected. If you can do 24-hour ambulatory EEG, that's very useful, but of course has technical and cost limitations. And withdrawing anti-seizure medicines is generally only done during inpatient video EEG monitoring. Okay, so epilepsy is a clinical diagnosis, and you should use the EEG to answer a specific clinical question and know how the result may affect management. And only repeat the EEG if you think it can help management. And the other thing that may be useful to keep in mind is who you're writing the EEG report for. And you can sometimes think of it as the body of the report is for another electroencephalographer, or for you if you're reviewing records of a patient who's having a subsequent recording. And the conclusion is for the referring physician. So it's fine to describe potential epileptiform discharges in the body of the report, as long as you make the implications clear clinically in the conclusion. Thank you very much.
I'm sorry, that was very bizarre that some of the EEGs got rotated 90 degrees. That was not apparent on my slides.
Thank you, Dr. Theodore. So for our attendees, please put your questions in question answer session. We'll have one more talk on imaging in epilepsy, and then both our speakers will take your questions. So please put your questions in the question and answer section, type them out, and we'll pick them and answer them. Thank you, Dr. Theodore. Our next speaker is Dr. William D. Gaillard. Dr. Gaillard is Professor of Neurology and Physiology, is the Chief of Division of Child Neurology and of Epilepsy and Neurophysiology at Children's National Medical Center in Washington, D.C., USA. He's the Director of the Comprehensive Pediatric Epilepsy Program and Associate Director of Children's National Research Institute Center for Neuroscience Research. He's also Professor of Pediatrics and Neurology at George Washington University School of Medicine. He's also professor at Georgetown, professor at University of Maryland, and has a long-standing collaboration with Clinical Epilepsy Center at NIH. And he's professor at a few other universities that I won't mention. His innovative research involves MRI, structural and functional imaging, and he's been a leader in research on MR imaging in epilepsy, and it's a great pleasure to welcome him and hear his talk.
Good morning, and thank you for the opportunity to talk to you today about imaging and MRI. I am William Davis Gaillard. My disclosures are mostly grant funding that support my work and clinical activities. This is a talk about epilepsy and imaging. Imaging is pursued to establish an etiology, which provides prognostic information to guide evaluation and therapy and to direct treatment. For example, if you have a brain tumor or you're considering about epilepsy surgery. There are different levels of image findings that help direct your treatment and urgency of care. Most studies are normal. Many have nonspecific or incidental findings that are not germane to the patient's epilepsy, such as periventricular leukomalacia, a Chiari-1 malformation, or arachnoid cysts. You may identify or confirm a remote static lesion, such as an old stroke or a malformation of cortical development. You may identify cause based on patterns of subtle abnormalities. So here you may find a pattern that suggests remote hypoxemic encephalopathy or particular genetic syndrome, such as Walker-Warburg syndrome. You may identify a cause of an epilepsy that does not require urgent intervention, but is potentially amenable to epilepsy surgery, for example, a focal cortical dysplasia or a cavernous hemangioma. You may identify a subacute process that has clear therapeutic, diagnostic, and prognostic implications, such as a brain tumor, a leukodystrophy, or a metabolic disorder. And finally, uncommonly, usually in medical emergencies, one finds an acute process that may require urgent intervention, such as an acute stroke, a CNS hemorrhage, or a brain abscess. Who to image? Any child with evidence of focality on history or exam or EEG. Any child less than 2, because their primary generalized epilepsy is uncommon in this setting. Anyone with a symptomatic generalized epilepsy, such as infantile spasms or Lennox-Gastaut syndrome. I would also say anyone with failure to control or worsening epilepsy. Those with new onset seizures, likely status epilepticus in the setting of a medical emergency. When resources are limited, one may need to prioritize and triage who has access to imaging. And here I would say those with highest risk, those who are acutely medically ill, those who are infants, and especially those in whom 2 medications have failed to control the epilepsy. There are some people in whom there really is no need to image, and these include the epilepsy syndromes, childhood absence, and juvenile absence epilepsy, juvenile myoclonic epilepsy, and self-limited epilepsy with central temporal spikes. One only images these children if there is an atypical course or a poor response to treatment. The imaging modalities are CT and MRI. I will mostly be talking about MRI. Functional imaging modalities and diffusion-weighted imaging with MRI can be pursued when one is considering epilepsy surgical considerations. So CT is commonly available, but it has poor resolution. It is performed only in an urgent setting or when MRI is absolutely not available. Here you're looking for semi-acute processes such as a stroke, CNS hemorrhage, a large tumor, cerebral abscesses, cysticercosis, or critical hydrocephalus. The challenge is that false negatives are common and they may provide false reassurance. And in unskilled hands, especially in adult imaging centers, it confers radiation. Here are examples of CT findings. You can identify the hemorrhage here associated with an AVM or toxoplasmosis in a child with early onset seizures and a congenital infection. Protocol to pursue, these are the protocols for those 2 and above. There are special considerations for those who are infants or those less than 24 months. And these have been recently upgraded or optimized with the Harmony protocol, which I will discuss in a moment. These are high resolution 3D T1 weighted imaging with 1 millimeter resolution that is cubic millimeters, axial and coronal T2. This is especially important in children. 3D FLAIR imaging and imaging along the axis of the hippocampus to identify hippocampal abnormalities and medial temporal sclerosis. I should note that gadolinium is rarely necessary and only used when you consider or are concerned about a tumor or about an inflammatory process. Most abnormalities could be identified without the contrast, and if contrast is needed, can be administered later. So this is Harness, not Harmony, but Harness MRI. This is the recommendations for those who are older children and adults from the recent ILAE statement. So the 3D T1 weighted MRI a flare turbo spin sequence of 1 millimeter resolution, and imaging along the long axis of the hippocampus. And I would argue in children, one needs T2 sequences as well. So the reasons for these and some comments are that 3 Tesla scanners are better than 1.5 Tesla scanners, and I suspect 7 Tesla scanners are better yet. However, you can do most of the things that you need with high quality 1.5 Tesla imaging. You want to decrease the slice thickness because abnormalities in the cortex, which is 2 millimeters wide, need greater than 2 millimeter resolution to identify. And thicker slice sequences will not identify these abnormalities. There are some pulse sequences that are not commonly used that may identify abnormalities or help define the abnormality, such as magnetization transfer imaging, MR spectroscopy in metabolic conditions, and susceptibility weighted imaging, as well as DWI and arterial spin labeled imaging. There are special considerations for those less than 24 months or infants. Here, axial T2 weighted imaging in at least 2, if not 3 planes is absolutely essential, as T1 imaging and flare imaging are less useful in this population. This is because of the changes in signal associated with altered or maturing maturation of myelination that changes the characteristics of signal intensity in white matter and gray matter, which makes it difficult to identify cortical abnormalities. And there will be examples of abnormalities that come and go in this age with imaging. So I'll talk about 2 series that talk about imaging in new onset cohorts. Here are infants here less than 36 months. Almost everybody had either 1.5 Tesla or 3 Tesla MRI, and the very large majority had an epilepsy imaging protocol. And here, an abnormality was found in 40% of those imaged. This was relevant in 25%, roughly, and more important, in 10% of patients, one could find a cause that was potentially amenable to surgery. These findings are acquired, such as anoxic ischemic injury, strokes, trauma, and infectious etiologies, or those which are remote structural and static, such as malformations of cortical development being the most common abnormalities found. These are similar hit rates compared to an adult series of 2,000 patients using a 3 Tesla MRI from Britain, showing that nearly 40% of patients had abnormalities, 20% or 1/5 were abnormal and relevant. The distribution of causes is somewhat different, more brain tumors and more mesial temporal sclerosis, but again, a very high yield of identifying a structural abnormality that is the cause of the epilepsy that also has prognostic and therapeutic and treatment implications. One also has a high incidence of incidental findings. If you look at epilepsy surgery series from the 2004 ILAE study, this is not an epilepsy surgery talk, but I think this is important to bear in mind, is in those patients who underwent epilepsy surgery, 40% had a focal cortical dysplasia, 20% tumor, 10% stroke, and 7% MTS. Thus, these can be acquired with high quality imaging very readily, and they may alter what you do. This is important because in this follow-up study of 1,000 patients in 2010 from the 2004 study, in those patients who had a clear MRI abnormality at 1.5 Tesla and who had a complete resection of that abnormality, 85% achieved seizure freedom. If you did not completely resect the abnormality, seizure freedom was less likely to occur. If the MRI was normal, the success of epilepsy surgery was less, except in the setting where there was an abnormal functional study with PET, SPECT, or 3D source localization. This is a study from University College of London looking at surgical outcomes in patients with focal cortical dysplasia, showing the high likelihood of achieving seizure freedom, but also that delays in surgery are associated with delays in the likelihood of achieving seizure freedom. And also the 3 Tesla scanners are superior to 1.5 Tesla scanners in determining long-term outcomes. So I would like to go through the various findings that you see on MRI. This is not exhaustive, but these are the main categories of findings. So the first is vascular, where you can have a cavernous hemangioma. You can see the hemosiderin from the bleeds. In the middle is an arterial venous malformation, the bag of worms seen in the left inferior frontal cortex. And on the far right, a patient with an old MCA stroke, likely perinatal. Brain tumors are next. In children, these tend to be low grade. Occasionally, we'll have a high grade glioma. But for example, and they may or may not enhance with contrast. So here's an oligodendroglioma, a ganglioglioma, and a pilocytic astrocytoma showing characteristic features. Mesial temporal sclerosis used to be the most common entity upon which people operated in the 1990s and early 2000s. Now it is more often associated with focal cortical dysplasia and other dual pathology, but the hallmark features are the hippocampus here on the left, which is small compared to that on the right. It has increased signal and it has lost internal architecture and the external architecture as well. These are the diagnostic criteria for mesial temporal sclerosis, also amenable to epilepsy surgery. Phacomatoses and heterotopias, which are part of malformations of cortical development. So the most common one that you will know is tuberous sclerosis complex with cortical tubers. They're hypomyelinated hamartomas. They're mostly subcortical. They're mostly in the cortex. They tend to be dark on T1 and bright on T2. They may or may not enhance, or they may or may not be calcified. And you can see them here diffusely in this child with series of imaging. Church-Weber syndrome is effectively a cortical hemangiomatosis. This is associated with the V1 port wine birthmark, here showing atrophy, often calcified with railroad signaling on other imaging. And here are the hallmark features of this particular entity. Here is a patient with intractable gelastic epilepsy. These are mirthless laughs. And this is often the cause of this is a hypothalamic hamartoma, shown here in the right with the bar showing the size of the hamartoma. And then there are paraventricular nodular heterotopia. These are heterotopias that line the ventricular surface. The cause or the source of the seizures may be the heterotopia or the cortex to which it projects, or both. And you can see one in the arrow on the left and on the left side of the posterior ventricle on the right. Focal cortical dysplasias are the most common finding and the most common surgically amenable etiology for epilepsy. They are classified as 1, 2, and 3. 1 is dyselimination with normal appearance of neurons. Type 2 has abnormal elimination of neurons but has dysmorphic neurons, and type 2B also has balloon cells. And type 3 are the dual pathology with MCS2 or vascular malformations. The hallmark features of focal cortical dysplasia are they tend to be cortically bright, they are thickened, and they have blurring of the gray-white matter junction as shown here on T1 and T2 weighted imaging in the red circle. Here with the blue arrow is a bottom of the sulcus dysplasia. This happens to be a type 2 dysplasia, showing again the thickened cortex, the blurring of the gray white matter junction. Also exquisitely responsive to surgery. Here is the transmental dysplasia with balloon cells of Taylor, or a focal cortical dysplasia type 2B. Almost invariably has a somatic mutation in the mTOR pathway later on in development. You can see the bright T2 signal in the tail going to the ventricular surface. This is pathognomonic for a type 2B focal cortical dysplasia. Hemimegalencephaly is an mTORopathy that occurs earlier in cell cycle divisions involving the entire hemisphere and may involve the contralateral cerebellum, showing ventricular abnormalities widespread and an enlarged hemisphere with loss of gray-white matter distinction, often almost invariably associated with refractory epilepsy. And here is a patient where the blue arrow showing blurriness and brightness in the temporal tip, indicative here often of a type 1, but sometimes a type 2 dysplasia. This may or may not be associated with mesial temporal sclerosis. Here is a patient imaged at 1.5 Tesla and 3 Tesla. You can see the abnormality at 1.5 Tesla in the left mesial frontal region. It is more readily apparent at 3 Tesla in terms of extent and signal abnormality, and this helps the surgical outcome if you choose to operate. Some pulse sequences may convert additional information or delineate the abnormality. Here is a bottom of the sulcus dysplasia, which on close inspection is apparent, but it is more easily identifiable in the magnetization transfer imaging in the lower right-hand corner where the blue circle is. And here's susceptibility weighted imaging, which images iron and calcium. And you can see the red arrow, the delineation of the abnormality that is seen in the blue circle to the left. Images may, or the imaging the abnormalities may come or go in the first 2 years of life because of the trajectory of maturation of white matter and cortical development. And this really requires mostly T2 weighted sequences because T1 and FLAIR imaging is less helpful in this setting. So here's an example of a 7-day-old with neonatal seizures with a clear left mesial frontal focal abnormality, which is a focal cortical dysplasia, which you cannot identify at imaging at 1 or 2 years of life. Similarly, there are abnormalities which you cannot see early in life, which appear after myelination is complete. So here at 4 years, you can see in the left anterior temporal lobe the brightness and the blurring of the gray-white junction indicative of focal cortical dysplasia that are not apparent in the earlier age imaging. And here is imaging of cysticercosis, one of the most common causes of epilepsy across the world, showing the outline, the contrast enhancement, and the scolix inside. You can look at blood flow with arterial spin labeling. This really is only helpful for increased perfusion associated with frequent seizures or status epilepticus, but it's very easy to acquire and to look at. So I mentioned it. This is associated with with seizures. Here are causes of epilepsy that you can establish with imaging that give you prognosis, but are not amenable to surgery. So here is, on the left, is someone with lissencephaly, and on the right, bilateral schizencephaly. They are not candidates for curative surgery. And here are the hallmarks of a metabolic cytopathy, cerebellar atrophy, increased signal in the deep gray matter areas. This indicates a need to search for genetic and metabolic causes and its own line of treatment. Not candidates for surgery, but obviously this has implications for prognosis and management and treatment. There are some patients who are not good candidates for surgery. They have diffuse bilateral abnormalities. The seizure focus overlaps with eloquent cortex, genetic epilepsy, metabolic disorders, and progressive disorders. Sometimes, however, properly selected patients with bilateral focal abnormalities or genetic disorder with a clear focal abnormality may benefit from surgery. This may be palliative, but not curative. This is the workflow track from the ILAE, indicating that in the early evaluation of someone for epilepsy surgery, MRI is paramount, and then functional imaging is pursued based on MR imaging or the issue of eloquent cortex. So in summary, there is no substitute for a high-quality, high-resolution MRI epilepsy protocol, preferably at 3T, but if not available, 1.5 Tesla will do, reviewed at initial evaluation and, if necessary, after non-invasive evaluation by skilled people who are able to read pediatric MRI. Who needs an MRI? Really everyone, but those, except those with the some of the primary generalized epilepsy and as I had mentioned, self-limited epilepsy with central temporal spikes. But really, if someone does not respond to anti-seizure medications, or they have a deteriorating course, or they are young, then those are the patients in whom one must push for imaging. When do you do imaging? Preferably at onset. But again, as I mentioned, when resources are limited somewhat later on with the conditions I described. And I would also argue in this day and age, genetic testing is often pursued in parallel to imaging wherever possible, especially in those who are young, because the identification rate with current genetic testing is extraordinarily high and is as high as it is with imaging and also has implications. So with that, I would like to thank you very much for your kind attention, and I am happy to entertain any questions during the question and answer session. Thank you so very much for your attention.
Thank you so much, Dr. Gaillard and Dr. Theodore. So again, a reminder to participants, please put your questions in the Q&A box. The first question is for Dr. Theodore. What do you do when you have bilateral independent temporal spikes? Is that focal or generalized epilepsy?
It's more likely to be bilateral focal onsets if that's all you have. But clearly in that situation, you need to do more recording to categorize the epilepsy syndrome in more detail. If that's all you ever see on a series of EEGs, then I don't think it's likely to be a generalized epilepsy syndrome. But that may be different in children. So I'm talking about adults, and Dr. Gaillard can comment on the situation in children.
It is the same in children.
All right. Is it important to stop a routine benzodiazepine anti-seizure medication when recording an EEG?
Well, there's always a risk when you stop any medication of the patient having more seizures. As long as you know what they're on, then I think you can account for the effects of the drug. Of course, benzos will give you lots of excess beta activity, and sometimes that can make patterns look more spiky. So you have to watch out for that. But it's really not a good idea in routine outpatient EEGs to stop anti-epileptic drugs, except in very special circumstances.
All right.
The other thing is that some of the benzodiazepines have very long half-lives. So you can stop a drug like clonazepam, and things may happen, long after the patient has left the EEG lab.
Okay. So next question is about imaging. As many times we find temporal lobe arachnoid cyst when imaging patients with epilepsy. Is it incidental finding or causative that may be amenable to surgery? Both of you.
Well, so for the large majority of people, arachnoid cysts are incidental findings and they are not related to the epilepsy. There are unusual circumstances where that rule may not hold, in which case surgery is an option. But by and large, you really have to demonstrate that it's relevant. In most cases, it's not relevant.
I agree with that.
So next question, can you explain the occurrence of non-epileptic seizures in patients with epilepsy? So co-occurrence, epileptic and psychogenic non-epileptic spells.
Well, so as was said earlier, it's quite common to see that combination. Now, so there are a couple of possible explanations. One is that the non-epileptic events, and that's a terrible term actually, because there's so little we really understand about the brain that it's presumptuous of us really to call things non-epileptic events. All we can really say is that they're events not associated with our ability to record physiologic signals from the brain. So patients, who knows what they really are. But another thing is that patients very often feel sort of stressed to perform, particularly when they're undergoing video EEG monitoring. And sometimes the other thing that can happen is that when you're doing anti-epileptic drug withdrawal, you can get all kinds of unusual symptoms, particularly with withdrawing some of the sodium channel agents. You can get lots of psychiatric symptoms. So many things can go on, which might be called non-epileptic events and really are physiological, but in a way we don't understand.
All right. Can you comment on secondary bilateral symptoms? Clinically, can these patients present with focal seizure semiology and have generalized discharges in EEG?
Yes, I think so. Dr. Gaillard?
I would agree. So they are a form of focal seizures. And the last half of the question just disappeared from the chat.
So they present with focal seizures, and EEG appears to be generalized. But of course, carefully looked at, such patients have focal onset.
Yeah, but I would also say, at least in pediatrics, that the EEG may appear to be generalized, but in fact it is focal. And focal lesions can give rise to what appears to be a falsely generalized pattern, which may persuade you, which is important for choice of medications and also for surgical consideration. So you have to be very careful about calling something generalized.
Some of that may also depend upon the montage that you're using. And if you were able to have more closely spaced electrodes, you might detect focal onsets that get obscured with the standard 1020 system.
So one more question. What is the importance of sleep in regarding routine EEGs, and how do you induce sleep?
Well, in adults, we generally do sleep deprivation. And in some people, that does provoke seizures. It's important to keep in mind that sleep deprivation can provoke seizures in perfectly healthy people. That's was first noted actually during the Second World War in RAF pilots who were going on very long bombing raids over Germany. Those were obviously very highly screened, very healthy people. So it's a phenomenon. In children, Dr. Gaillard can comment.
Well, but I think the main thing about sleep deprivation is to allow someone to fall asleep in recording the EEG, because it is early sleep where you may identify abnormalities. So you want to capture both wakefulness and sleep, and you're more likely to achieve that if you sleep deprive somebody. So nothing special about there may not be something special about the sleep deprivation other than the desire to get both states.
All right. A brief answer to a tough question. How long should children who experience seizure be on treatment for?
Till those seizures stop. So there is increasing debate about whether you can withdraw medications after 6, 12, 18, or 24 months. The majority will remove medications after 2 years of seizure freedom, and EEG helps you determine the likelihood of success. If the EEG is normal, you're more likely to be successful. If it's abnormal, a little bit less so, but you still may be successful. But after 4 years, regardless of what the EEG shows, and unless there are other medical contraindications or the child has a propensity for status, every child deserves a chance to come off their medications.
Thank you. And that's going to be one of the topics of 2 upcoming talks on seizure medication, seizure treatment, and discontinuation of anticonvulsants. So thank you, Dr. Gaillard and Dr. Theodore. We'll go on to our next speaker. That is Dr. Judy Taper. She comes to us from Kingston, Jamaica, and really practicing epilepsy in a small island, as our conference is, and one of the leaders and organizers of this meeting. So I really thank Dr. Taper for that. Dr. Taper did her MBBS from University of West Indies, and then FRPCs from University of Toronto in pediatrics, postgraduate in pediatrics at University of Toronto, and then pediatric neurology at University of Toronto. And she has been practicing both in academic and clinical practice since then in Jamaica, Kingston. Thank you.
Greetings, everyone. I wish to thank Dr. Kapoor and the North American Commission for inviting me to speak to a unique and diverse group from all around the globe, spanning many different time zones on this topic, choice of first anti-seizure medicines, matching treatment to syndromes. I have no disclosures to declare. So my outline consists of defining epilepsy syndromes. We're going to go into the principles of using anti-seizure medication and then discuss the choice that's appropriate for our seizure type. And we're going to match the anti-seizure medication to the patient's profile, paying attention to special groups, females and females of childbearing age, the elderly, and children. So by definition, an epileptic syndrome is a group of clinical, or syndromes are a group of clinical entities that are reliably identified by a cluster of electroclinical characteristics. And by that, we mean that the semiology of the seizures and the EEG findings are characteristic of that syndrome. Seizures may either be focal, generalized, or combined focal and generalized. Syndromes often have age-dependent presentations. They have a range of specific comorbidities, and they're often supported by specific etiological findings. The diagnosis of a syndrome provides us with guidance in management and in counseling patients regarding prognosis. In March of 2022, the ILAE Task Force on Nosology and Definitions published 4 position papers on the epilepsy syndromes, and they classified them in age groups: syndromes which onset in the neonates and infants, childhood, syndromes that onset at variable ages, and the idiopathic generalized epilepsies. Of the epilepsy syndromes which onset in neonates and infants, they were divided in 3 groups: the self-limited epilepsies, and by self-limited, it meant that these seizures resolve spontaneously over time with or without treatment, and they carry a good prognosis. The developmental and epileptic encephalopathies, these are a condition in which the seizures are intractable, and the seizures themselves, or the epileptiform discharges, results in regression and progressive decline in the children's cognitive, language, behavioral, motor function, and these children are often intellectually disabled or have global developmental delay in the neonatal and infant stages. This includes our infantile spasms, which are now called infantile epileptic spasm syndrome. There are those syndromes in the neonatal and infantile stage, which are etiology-specific syndromes, and this includes pyridoxine-dependent syndromes, as well as glucose transporter 1 deficiency syndrome. Childhood onset epilepsy syndromes include self-limited focal epilepsies, genetic generalized epilepsies, and developmental and epileptic encephalopathies. The self-limited focal epilepsies are all age-dependent. These children are normal neurologically and cognitively, and remission occurs spontaneously over time. Self-limited epilepsy with centrotemporal spike, which we once called benign Rolandic epilepsy with centrotemporal spikes, is the commonest of the epilepsy syndromes that we see in childhood. It onsets at 4 to 10 years of age and is characterized by nocturnal focal seizures, which often evolve quickly to bilateral tonic-clonic seizures with a characteristic centrotemporal spikes seen on EEG. Of the genetic generalized epilepsies, childhood absence epilepsy is the most common, and this consists of recurrent absence seizures which onsets between 4 to 11 years of age, and it has a characteristic 3 Hz spike and wave discharge seen on EEG. The seizures, once they occur, are always very recurrent, these absence seizures, and if left untreated, it results in a decline in the child's school's performance. So it's very important that we recognize and treat this syndrome. Most of the time, these seizures remit by puberty. Of the developmental epileptic encephalopathies, the Lennox-Gastaut is the one that we see most commonly, and this is characterized by multiple generalized seizure types, atonic and tonic seizures, often very challenging to treat, and there's a characteristic EEG pattern seen. The epilepsy syndromes with variable onset include generalized epilepsy syndromes, focal and combined generalized and focal epilepsy syndromes. Mesiotemporal lobe epilepsy with hippocampal sclerosis is in this group. Our idiopathic generalized epilepsies comprise 4 groups: childhood absence, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures. There's often an overlap of these syndromes, and the seizures may be a combination of absence, myoclonic, tonic-clonic, and myoclonic, tonic-clonic seizures. These patients are often developmentally normal, though comorbidities are common, such as mood disorders, attention deficit disorder with hyperactivity, and learning disorders. So, going into our anti-seizure medication, our anti-seizure medications are classified based on the year in which they were introduced. So we have our first generation, second and third generation anti-seizure drugs. The first generation starts with phenobarbital, introduced in 1910, and this ended in the 1980s. The second generation started with in the 1990s to 2000 with oxcarbazepine, lamotrigine, topiramate, and levetiracetam. And the third generation anti-seizure medication ended with the introduction of cannabidiol, cenobamate, and fenfluramine in 2020. There are others to the third generation also. Treatment should be considered and offered to a patient once their diagnosis of epilepsy is made. And this diagnosis is made on the basis of 2 or more unprovoked seizures, or after a single seizure with a risk of high recurrence, a relevantly abnormal EEG or neuroimaging, or if a diagnosis of an epilepsy syndrome is made. We should always discuss the patient's diagnosis with them and their families, and we discuss the management, including treatment, the benefits, and the risk of the anti-seizure medication. Treatment is usually long-term, and we say that we treat seizures until the patients become 2 years seizure-free, and sometimes seizures may be lifelong. The first anti-seizure medication should be selected on the basis of the seizure types or the epilepsy syndrome. Other important selection criteria include the patient's characteristics, such as their age, gender, and comorbidities, drug efficacy, adverse effect profile of the drug, potential drug-to-drug interactions, and last but not least, cost, which is important to us in low resource settings or resource limited settings rather, but important to everybody. Principles of treatment. We always start by using monotherapy. Our first choice of the anti-seizure medication is the one most likely to be efficacious and least likely to cause adverse drug reactions. The dictum is we always start low and go slow. That is, we start at a low dose and we slowly titrate upwards to a therapeutic dosage or target. Once we have achieved seizure freedom, we stop increasing the dosage. And we are trying to achieve the seizure freedom with minimal adverse reaction. Patient education is key, as I said before, and one of the things we need to counsel our patients about is compliance, because without compliance, there is no seizure freedom. As I said, we increase our dosage slowly. We titrate up to a dosage until the patient has achieved seizure control, or If there is toxicity or intolerability to the drug, we may need to discontinue that drug and use another. We always try 2 monotherapies before proceeding to combination therapy. And I say that because we should not have a patient on 2 subtherapeutic dosage of medication. We always increase the single monotherapy to its maximum. And if the patient is still having seizures, we consider adding a second monotherapy or a second add-on drug. Therapeutic spectrum of anti-seizure drugs are broad-spectrum drugs used for treating both focal and generalized seizures, narrow-spectrum drugs used primarily for focal and focal to bilateral tonic-clonic seizures, and there's a narrow-spectrum drug used primarily for generalized absence seizures, which is ethosuximide. So of the broad-spectrum drugs, we see there these treat both generalized and focal onset seizures. We see first generation valproic acid, and these are in order of alphabetical order. We have lamotrigine, levetiracetam, and topiramate as our second generation, and our third generation is as we see there. Our narrow spectrum drugs used primarily to treat focal and focal to bilateral tonic-clonic seizures. Our first generation consists of carbamazepine, phenobarbital, phenidone, and primidone. Our second generation, oxcarbazepine and gabapentin, and the third is as we see there. So there have been treatment guidelines published by the American Academy of Neurology, the American Epilepsy Society, as well as the International League Against Epilepsy, and the UK NICE group and the Scottish group. And we see there that for monotherapy for adults with newly diagnosed epilepsy with focal seizures, carbamazepine is recommended across the board, and it has level A evidence of efficacy. Lamotrigine and oxcarbazepine are also recommended by all bodies. So, in choosing our first anti-seizure medication, we always relate it to the seizure type. And for focal onset seizures, including focal to bilateral tonic-clonic seizures, the first-line monotherapy is carbamazepine. Oxcarbazepine as well as lamotrigine may also be considered for first-line monotherapy for focal onset seizures. For our generalized seizures, valproate is the first-line monotherapy of choice. For generalized tonic-clonic seizures, for myoclonic seizures, as well as for absence seizures. However, for absence seizures, we also have the option of using ethosuximide if it's accessible to us. And this perhaps should be our first choice, as the side effect profile is more benign than that of valproic acid, and it's also cheaper. For unclassified seizures, valproate is the first-line monotherapy of choice. Valproate is the first choice for generalized tonic-clonic seizures. However, it should never be used in females of childbearing age due to its dose-dependent teratogenicity. Pregnant females, if exposed to valproate in the first trimester, have a 3-fold increased incidence of having a child with major malformations. And these include neural tube defects, cardiovascular, and orofacial defects. In addition, they are at risk for having increased neurodevelopmental disorders. All of the anti-seizure medications do carry some teratogenic risks. Carbamazepine, we also know of fetal phenytoin syndrome. However, lamotrigine and levetiracetam have the lowest risk, and these should be considered in our females of childbearing age. Valproate can cause weight gain, so if a patient is obese, we perhaps should consider not putting them on it. It can also be hepatotoxic, and we see this most in our young patients less than 2 years, especially those who are on polytherapy. For our pediatric patients over 4 years of age, the anti-seizure medication recommended for adults as first-line monotherapy applies to that pediatric age group. Phenobarbital is the treatment of choice in the newborn and also in infants. Valproate, phenytoin, oxcarbazepine, levetiracetam, and the benzodiazepines are all approved for use in infants less than 2 years of age. And for the elderly, the lamotrigine and gabapentin is recommended as the first-line monotherapy for focal onset seizures due to their side effect profile and their drug-to-drug interaction. We should make note that carbamazepine, oxcarbazepine, and phenytoin worsen absence and myoclonic seizures, so we should not use these in childhood absence or juvenile absence epilepsy, juvenile myoclonic epilepsy, or Dravet syndrome. Lamotrigine may worsen myoclonic seizures in some cases. Carbamazepine can be very sedated and can also result in hyponatremia, and this is one cause these are common causes of discontinuation of the drug. It can also cause a photosensitive skin rash. Carbamazepine decreases the efficacy of the oral contraceptive pill, and so we need to advise our patients on carbamazepine that they would need to augment their contraception or add another contraception. Lamotrigine can result in a photosensitive skin rash, which can even lead to the Stevens-Johnson syndrome, which, as we know, can be fatal. So to decrease the incidence of this happening, we always start lamotrigine as a subtherapeutic dose and very, very slowly titrate up to a therapeutic level. So in summary, we treat patients with newly diagnosed epilepsy. The choice of anti-seizure medication is based on the seizure type or types, and we always aim for monotherapy. We choose an anti-seizure medication that has the best efficacy with the least adverse drug reactions, and we tailor the treatment to the patient's profile. Valproate should never be given to females of childbearing age due to its teratogenicity. And if there's any message that we gain from listening to this talk, this is the one message I'd like to leave with you, that of not giving valproic acid to females of reproductive age. Thank you.
Thank you, Dr. Taper. Again, I'll remind the participants that you can put your questions in Q&A box and we'll get to them after the next lecture. And the next speaker is Dr. Dave Clark. Dr. Clark is professor of neurology and pediatric neurology at University of Texas, Austin, at Dell Children's. He received his medical degree at the University of West Indies in Mona, Jamaica. He completed his first 2 years of pediatric training at Overlook Hospital, then an affiliate of Columbia University of Physicians and Surgeons. He completed pediatric neurology at University of Michigan Medical Center in Ann Arbor, Michigan, and then went on to Toronto Hospital for Sick Children for training in epilepsy and sleep. He's a board-certified pediatric neurologist, but beyond that, he has great special interest in medical and surgical management of surgical epilepsy. He's spent quite a bit of his time building a Caribbean League Against Epilepsy, along with Dr. Hamza Ali, who I see is among the audience here. And he's going to talk to us about what happens when the first-line drugs fail and when to stop medications. Thank you.
I'd like to thank the organizers for inviting me to give this talk. I'm going to be speaking about what should be your second choice if the first medication fails, and when should you consider discontinuing anti-seizure medicines. I have no conflicts pertaining to this talk. We all know now from Kwan and Brody that if your first medication is given correctly, about 50% of individuals, give or take, will stop seizing. But after that, you have to entertain, what else should I use and when should I use it? And that study has been updated, and it has shown 20 to 40% of individuals over time may not be adequately controlled on medications alone. We have multiple medications, but the question is, where has multiple medications? Not everyone has access to these medications. So if you fail one medicine, what do you choose next? Life is never that simple, just to look at medications alone. What about sustainability? What about medications that are available? So we're going to try and consider some reality here. What are the consistent medications available, especially in small island states or underserved areas, where the treatment of an epilepsy syndrome, seizure type, was it cause specific? Was the diagnosis correct? Do we know what we're trying to manage? Was the first AED used a correct fit? What are the determinants of health? Fiscal strength, what's the fiscal strength? There are so many questions. Should we consider non-medical management earlier in some cases if we're strained to find medication? Some countries may have less than 5 medicines to use. So if you have a very limited number of medicines to use if you fail the first one. Others 5 to 10, and then there's this huge schism that North America, Europe, and some other what are deemed first or high income countries, sometimes they have greater than 25 medicines. So there's that inequity we have to consider. Again, was the diagnosis correct? Chronic seizure, sent here by Dr. Natron. What was this? Chronic seizure. And is this J event? I would suggest that all of these different types of seizures are events, none of them are seizures. How about focal or partial onset seizures? Temporal lobe, occipital, frontal, parietal. They all have non-seizure mimickers that we have to consider. Was the management of the epilepsy syndrome, seizure type, or cause appropriate? Was it truly a generalized syndrome? That is, did they have the correct seizure type, linking it with the cognition, linking it with the EEG if available? i.e., was it a genetic related Lennox-Gastaut syndrome? And there are many seizure types within these syndromes. Was it a structural or focal lesion causing a Lennox-Gastaut type picture? Were they more progressive or aggressive developmental epileptic encephalopathies? Or were they more genetic generalized epilepsies in the generalized form? Or more focal epilepsies that may be amenable to surgery? What were the first AEDs or anti-seizure medicines now? We know what has been suggested prior by Dr. Tapper. Expertly done, showing the relationship between seizure types and medications. But was it truly a failure, a treatment failure, or was it compliance? Was it side effect related? Was it toxicity related? Was it appetite? Could they use the correct medicine at the time? What are the other considerations? Monotherapy, twice daily, greater than 2 times daily. How do you do that in areas where somebody may have to travel quite a distance to school 3 times daily. Or if mom or dad works late, regardless of where you are, how do you give it at night? Do you trust the person, the adult, to take their own medicine if they may be having seizures occasionally? How does oral bioavailability and protein binding come into being when you're adding a medication? Plus, you have to look at drug-drug interaction. They have some medications that we frequently give, valproic acid, clobazam, that interacts with many. Whereas they have others, levetiracetam, breviracetam, lacosamide, that may not have that interaction. You may want to consider these medicines in instances when you can't take that chance of drug-drug interaction. You also want to avoid compounding effects. So if somebody's already fatigued, you may not want to give clobazam. If there's weight gain and or hair loss, there may be a difficulty. Or you don't want to give a lady divalproic acid because of the pregnancy issue. Stomach upset, GI symptomatology, ethosuximide. How about behavioral change? If you have clobazam initially causing some behavioral change, would you add something like levetiracetam? Likely not. So these are all considerations that you have to take. What are the social and or other determinants? Can the patient take medication? What is the cost? Inability to get meds, are they available? 2 to 3 households split parents. One has to give the medication in the morning, one give the medication at night. The patient may be non-compliant. How about the health providers? Can you actually find an adequate health provider geographically? Is it rural versus urban? We know from many studies that most physicians and or practitioners practice in urban settings. Do you have an available epileptologist even by ear, virtual care? Can you send them a video, as the videos that had been sent to me before by my colleagues as suggested? Price is significant. Quite often, medications may be sourced from, say, India, South Central America. So therefore, cost may be prohibitive. What about the global inequities of drugs? I alluded to this earlier. You can see here North America in red has significantly more medications than, say, Asia Pacific. And within North America, there are significant barriers to some places getting meds. Europe, significantly more. And the Middle East and Africa, you see quite a bit less medications, inclusive of Latin America. So this inequity is significant. But even within states, you go through the exact same inequities described. What is the possibility of success? Do you always have to stop all seizures? In Rolandic epilepsy, for instance, if you have given oxcarbazepine and it fails to control seizures, but the individual has 1 to 2 seizures per year, how aggressive should you be? Or if it's a self-limited epilepsy with occasional seizures and you have treated 1 or 2 meds and that doesn't have effect, do you jump and do more? Or a nocturnal aura that's seemingly not affecting the person's quality of life post-surgery. How aggressive should you be? That is a question we have to ask, especially in poorly resourced areas or even adequately resourced regions. In some developmental epileptic encephalopathies with developmental problems as well as related epilepsy, neurocognition, etc. In a genetic progressive developmental epileptic encephalopathy, do you tolerate less frequent seizures but preserve alertness, interaction, quality of life? Lennox-Gastaut syndrome, MR negative, non-focal, how about targeting the atonic seizures and not all seizure types? Or with the infantile epileptic spasms, we know we have to be aggressive, so it varies greatly. A cortical dysplasia in the sensory hand area, we know we can't go after it. We're going to optimize medications. Do we tolerate occasional brief numbness or don't we? These are questions we have to struggle with. We can't just answer the question giving a second med.
We have to look at the patient in general. Would you entertain faster non-anti-seizure medicines intervention? For instance, with the K diet, GLUT1, PDD, aggressive tumor. How about the gray areas? You have a neonate with hemimegalencephaly, presents and start having frequent seizures. You've been through 2 medicines or even 1 medicine. Why wait? If you have surgery or they're amenable to surgery, why wait? You have a 9-year-old with a right frontal cavernoma, may or may not bleed, is fairly large. A surgeon is capable of doing it in your region. Do it. And or now with advent of laser ablation, which not everyone has. But if you have a low-grade lesion, would it be optimal for someone in a less resourced area to have the ability to do laser and not keep them in the emergency room? These are things that need to be explored, especially in the global sense. But taking all of this into account, Sharon Klein actually has a really nice outline in this article of what you would use, which were the common medications taken. But what would you use second? And I would suggest for spasms, if you've been through steroids, if you have vigabatrin, definitely use it. But if not, and you can use the diet to help, that's quite helpful. Valproic acid has helped, topiramate, benzos. The genetic generalized epilepsies, they have the good old levetiracetam if valproic acid hasn't worked, or ethosuximide for absence seizures being first line. But they have some pretty decent studies looking at lacosamide, which has been helpful, and our national recommendations here in the US, lamotrigine XR or levetiracetam. Absence, the same as you can see. And LGS, you have quite a few medications that you may use, but not all may help. Dravet syndrome, we have directed medicines, fenfluramine, stiripentol, CBD, but not everybody can get to many of those medicines. Do you want to try topiramate or the diet? And for focal epilepsy, a long list of medicines. Something you have to remember, there's some medicines you don't want to use. Truly generalized, you don't want to use carbamazepine. You may not want to use phenytoin. These are things that need to be taken into account. But you have done your due diligence. You've gotten this medication down. How do you stop it? We can see the recurrence rate here, about 39 to 51% after 2 years in this analysis. But more succinctly, Berg and Shanar have shown that about 25% at 1 year, 29% at 2 years. And the AAN suggests that there may be reduced risk if you're seizure-free for 2 to 5 years, so you may entertain weaning. A single reported seizure type is optimal. A normal neurological examination and IQ, and a normal EEG when available with treatment. So you want to probably do an EEG prior to weaning. 2 years may be optimal, but it depends. How about if you are fortunate to have surgery done? This has been looked at by our colleague, Dr. Yardi, and it has clearly shown that AEDs that are stopped, probably over time, you have a significant reduction. In individuals that even have breakthrough seizures, you can get to Engel class 1 during last follow-up at 48%. That's pretty significant. And a significant improvement by another 23%. Therefore, you're getting upwards of 75% improvement. If you look in totality of class 1, you're looking at 71%. And this is temporal lobe. Frontal less so, but you can make significant improvements over time. It also shows proved effect that the longer you wait to wean, the better. By significant, 10 to 25%. And it also shows that if you're seizure-free over time, there's a much higher probability of weaning successfully, especially if you're seizure-free over 2 years. So this has been quite a condensed version of the discussion. But as Albert Einstein says, everything should be made as simple as possible, but not simple. If you don't start somewhere, you're going to go nowhere, as per Bob Marley. So if the first anti-seizure medicine fails, make sure you're managing the correct condition. Is the patient taking the AED? What other sustainable anti-seizure medicines do you have available? Management should be directed. Seizure type, epileptic seizure type, underlying cause, epileptic syndrome. When should you stop? Probably in and around 2 years in most. Determine the seizure type. In some cases, non-medical management should be entertained early, I think, but that's debatable. And in both surgical and non-surgical cases, again, it looks like in and around the 2-year mark may be optimal. If you want to prove that efficacy, go a bit longer. But you may have to direct your management towards some individuals. And I'm just going to thank all my colleagues globally for having me help participate in the care of many of your children. I'll see some of you soon, some of you later, some of you as late as next year, but I'm very appreciative. And once again, I'll leave it open for questions here. Thank you.
Thank you, Dr. Taper and Dr. Clark. For our question answer session, I want to introduce one more panel member, Dr. Tim Welty, who's a professor of clinical science in College of Pharmacy and Health Sciences at Drake University. He's also director of research, innovation, and global initiatives for College of Pharmacy there. So I'm going to take chair's prerogative and ask the first question from Dr. Welty and two other panel members. Small island nations often experience catastrophic events in form of hurricanes or even earthquakes. And ILAE has worked towards responding to these emergencies. From your experience, Dr. Welty, what should be how should physicians go about making sure that the patients continue to receive medications when such emergencies arise?
Hey, thank you, Dr. Kapoor. So there are several things that I think should be done. First of all, I think working with patients to make sure that they have an adequate supply of medications. And what I would do is help them develop what I call a go box. So a supply of medications that usually would last for at least 2 weeks, that in the case of an emergency, they can grab that box and take it with them wherever they have to evacuate to. So helping them to make sure they have those supplies with them that would cover about 2 weeks worth of medications. I think the other things that need to be done, one is working with the WHO in terms of helping to add or make sure that appropriate medications are on the essential medications list, as well as the emergency health kit recommendations that are followed by many, many countries. I think the third thing is very carefully working with your local pharmacy groups and pharmacy associations about finding ways to help sustain the supply during crisis situations. And finally, as we're learning, some of the more prolonged crisis situations result in economic hardships for people, and looking for both non-governmental as well as governmental resources that could help people in paying for medications, especially in a more protracted or crisis emergency situation.
Thank you. I'm going to jump on to the next question and to the panelists. What is the role of anti-seizure medication drug level monitoring in management of seizures and epilepsy?
I think I could answer that to some extent. In some of what would be described as first generation agents,
it is more important primarily to not necessarily measure the drug levels alone, retoxicity, but make sure you have liver function testing done in CBC. The ultimate drug level, as they say, is the one that can reduce the seizures but have less side effects. But there are variations to that theme. But within the confines of small island states, and especially during with disasters, as you alluded to before, many persons have to leave their country during these disasters, and or you may not have the lab and or the fiscal strength to do repetitive drug testing. So some of the newer agents, and for instance, levetiracetam in some may be better. And I'll leave it open to the other panelists.
Well, I would like to say that in my resource-limited setting, drug testing or testing for drug levels, we don't do often. And sometimes when it becomes important, it's looking for compliance, whether the patient is actually taking the drug and you are up to therapeutic levels. They are expensive to do, and it only gives you an answer for that time. It doesn't tell you about what's happening in another 1 month or what had happened in the last X months. So there are constraints to doing drug levels in our resource-limited setting.
I would add, I agree with both Dr. Clark and Dr. Tapper. I don't know that there's a place for routine monthly, every 3 month measuring of drug concentrations. I don't think that it's useful, and I think it's somewhat a waste of resources. But there are certain situations where they may be helpful. What I would say is many times it's helpful to establish a benchmark. So you check a level, especially with the older medications where those concentrations may be more readily available. So those lab tests may be more readily available if the patient is well controlled and not having adverse effects. And then if you suspect that maybe the patient is non-adherent, or you have some other event come up like a breakthrough seizure or unexpected dose-related adverse effects, then you may want to check another concentration. But beyond that, I don't think that routine use of concentrations is useful in the clinical setting.
So Dr. Taper, you had mentioned about Depakote in women. What if it is helping a woman, and should we offer contraceptives and give the medication?
Well, I think that's a good point in that some females may have seizures that are very difficult to control and only controlled on valproate. And in that case, I think we would ensure that that person, that female, is on very adequate contraception and continue with giving the valproate. But we'd have to counsel our patients, I think, very in detail, letting them know of the teratogenicity of the valproate and the importance of using adequate contraception. Sometimes you have to use 2 contraceptions in order to prevent pregnancy.
One last question with quick answer, because we're running a bit behind. When do you say that patient has drug-resistant epilepsy?
Dave, I'll let you take that one.
I'll to be politically correct, I'll stick to the ILAE definition of failure of to adequately tried anti-seizure medications. But I'll also say it varies according to syndrome per se, as per some of our colleagues.
Thank you. Thank you so much to all of you. To participants, I'll remind you that as you see in the chat box, there is an evaluation form. We'd love to get your feedback about our talks today. Please fill that out, and that's required to receive credit for today's program. I see at least 100 of you here, so thank you for being here. Let me now introduce our next speaker. She's giving next 2 talks. She's Dr. Professor Danielle Andrade, who's a professor of medicine neurology at University of Toronto. She's medical director of the epilepsy program at University Health Network. She's also the founder and director of Krembil Brain Institute Epilepsy Genetics Program. She's the chair of the International League Against Epilepsy Task Force on the transition of patients with epilepsy from pediatric to adult care. She's a member of the International League Against America North American chapter. She's also our treasurer. She graduated in medicine from University da Federal in da Paraná in Brazil and completed her neurology residency in Hospital Graças in Brazil. She then completed Master of Science at the Hospital for Sick Children, University of Toronto, which was focused on protein therapy for Unverricht-Lundborg progressive myoclonic epilepsy. She's completed epilepsy and clinical epilepsy electrophysiology fellowships. She's a world leader in genetics of epilepsies, and we're really fortunate to have her give us these 2 lectures on genetics of epilepsies. Thank you.
Okay, so thank you very much for being here with me. I'm Danielle Andrade. I am an epileptologist from University of Toronto in Canada, and I'm happy to talk to you about the role of genetics in developmental and epileptic encephalopathies. So here are my disclosures, and here's a quick outline of things I will be talking to you over the next few minutes. So let's start with the first important concept in genetics of any disease in reality. So if you think about a mutation, if it happens either on the sperm or the egg, it means that every cell in the embryo will carry that mutation, and every cell in the entire organism will have that mutation. So this is the kind of mutation that we can detect if we do a blood test or saliva. We can see, even if the mutation affects mainly the brain function, if it is a germline mutation, we'll see in any cell of the body. The other side of the coin is if you have a somatic mutation. That happens after the egg and the sperm met and the embryo starts to be formed, and at some point during development you have a mutation. That mutation will affect only a group of cells, so not the entire body. One of the classical examples of somatic mutations is focal cortical dysplasia. So if you have a mutation that happened late in embryogenesis, you have only a small number of brain cells that are mutated, and you have a small focal cortical dysplasia, like something you're seeing here in the B square. But if you have a mutation that happened earlier in embryogenesis, you might have the whole hemisphere affected, like in a hemimegalencephaly. Now, remember, this is a somatic mutation, so if you do blood work, you might not detect the mutation that led to the hemimegalencephaly. You might need to do another type of testing. So this is basic concept 1. The second basic concept is regarding the etiology of the epilepsies. So this is a very nice picture you might have seen somewhere before. It shows our understanding about the etiology of epilepsies. In the past, we knew about trauma, stroke, cancers, infectious causes, congenital lesions, and a few other things. All the rest we call idiopathic epilepsies. Now we have added 2 new causes. One is the autoimmune, and the other one is the focal epilepsy with MRI detectable lesions. And all the rest we call genetic epilepsies. So they can be caused by a single gene, as you might have in some familial cases. Usually those are autosomal dominant, but could be recessive, could be de novo. And then you have the epilepsies with complex inheritance, where you probably have thousands of areas in the genome that By themselves, they do not have a large effect, but when you add them up, they have a larger effect. And then you have modifiers and other susceptibility alleles. So for instance, if you think of someone who developed seizures only after a stroke, you might also have someone in the same family that only developed seizures after a trauma. So they have some modifiers, so genes that lower their seizure threshold. But what we will talk most about today is the single gene. The epilepsy is caused by single gene, especially the epileptic encephalopathies. Before we go there, the third basic concept that is important to remind everyone is the mode of inheritance. So this is pretty clear. We have the autosomal dominant, the autosomal recessive, the X-linked, which might lead to disease in females in most cases because it can be fatal in males. Although there are some cases where the male is affected and the female might be normal or close to normal because she has another X. And then you have the de novo. That's where neither parent carry the mutation and the mutation happened somewhere either in the gamete or after conception. Okay, so now we get to the developmental and epileptic encephalopathies. So the first concept was epileptic encephalopathy, which was a developmental impairment secondary to epilepsy. But then it was realized that there were other patients that have impairment secondary to their underlying etiology, which is apart from the epilepsy. So we think that the phenotype that we see is really caused by the underlying etiology and probably the effects of several seizures in a young developing brain, plus or minus the effect of anti-seizure medications. That's a bit harder to quantify, but possibly the underlying etiology and these seizures. It's important to remember that patients with DEEs also have several comorbidities, and sometimes they can be as challenged to manage as the epilepsy. So the most common ones are, of course, intellectual disability, but then behavioral problems, psychiatric problems, autism spectrum disorder is very common. Movement disorders is also very common. We see lots of motor and gait abnormalities, sleep problems, digestive problems, and other systemic problems. So how are the seizures in patients with DEEs? Well, they can be of several different types, actually any type of seizure, and often the patient has more than one type of seizure. Patient with DE has more than one type of seizure. The seizures can start before or after the developmental delay is observed. And usually after seizures start, if there was a developmental delay before, it can be accentuated, or if there was not before, you can observe after the seizures start. And even if the seizures are controlled with anti-seizure medications, the developmental piece continues to be affected. So here are some of the genes that are associated with DEEs, and this is a paper published last year, and it shows that the most common one is SCN1A. Then you have KCNQ2 and a few others, but the large majority of the patients with DEEs have mutations in their private genes. So what that means is there's only a handful of patients with mutations in all these so-called other genes. The other thing to remember is that one gene can cause several diseases. So for instance, SCN1A is classically associated with Dravet syndrome, but it can also cause something more mild, such as GAPS plus, generalized epilepsy with febrile seizures plus. It could cause something severe like epilepsy of infancy with migrating focal seizures, or even perhaps more severe early infantile DEE, which is associated with a gain of function in most cases. Then you can have the flip side of that is one disease caused by several genes. So for instance, if you look at epilepsy of infancy with migrating focal seizures, which we just said can be caused by SCN1A, if you look here, SCN1A is actually not the major cause, but you have all these other genes that can cause. The ones in blue are associated with a de novo and only dominant, so just one allele mutated can cause the phenotype, but you have those in brown and red that are actually recessive, so you need to see the variant on both alleles. Another example of one disease and several genes, of course, is Dravet syndrome. Remember, Dravet is a clinical diagnosis, and even though 80 to 90% of the cases are caused by SCN1A, we have a small amount of patients that have variants in other genes, even though many times if you look at these patients after they pass their childhood, you see that they become different from patients with Dravet. So for instance, patients with PCDH19 tend to have more psychosis. Patients with STXBP1 tend to have a few movement abnormalities that are different, like tooth grinding when they are awake. Even though this can happen in Dravet, it's more common in STXBP1. So you start to see those differences as the patients grow older. Now, who should be tested for genetic epilepsy? Definitely those patients with drug-resistant epilepsy without a clear etiology. Those patients that have epilepsy plus intellectual disability, and those can be the classic DEE, or can be patients that have intellectual disability and develop a few seizures along their lives. Patients with malformation of cortical development, patients with symptoms that get worse as time goes by, even though they are on the right treatment. So of course, we have to think about progressive myoclonic epilepsies. And patients with dysmorphism or multiple congenital abnormalities, although it's best to refer those patients to a geneticist before we go on and order genetic testing. Patients that should not be tested, those with common forms of epilepsy, such as genetic generalized epilepsy, what we used to call idiopathic generalized epilepsy, or temporal lobe epilepsy, especially if they have normal intelligence. And why do we say that? Because those patients are more likely to have epilepsies that are caused by a large number of genetic abnormalities in several areas of our genome. And right now, we are not testing that on a clinical basis, even though we might be able to detect who has a higher tendency to have seizures based on their polygenic risk score. We're not doing that on a clinical basis yet. Those patients that have a clear structural reason for their epilepsy also don't need genetic testing. Patients that have well-controlled epilepsy probably don't need genetic testing. And why is it important to understand the genetic etiology? I think it's important, first of all, to end the diagnostic odyssey. So when patients start to have seizures, of course, the focus is on treatment, but there's always this question of why and why and why, and we do many tests. And part of testing is also to figure out the best treatment. Of course, genetic counseling is very important, and the appropriate choice of medications and or precision medicine. And that's what I'm going to talk about in the next few slides. So sodium channelopathies, it's very important to try and understand how our medications can affect patients with different sodium channelopathies. And if the channelopathy is a gain of function, our medications can have an effect that is completely different from that of if the patient has a loss of function. So for instance, SCN2A, SCN8A, and SCN1A, if there's a gain of function in one of those genes, these patients tend to respond well to sodium channel blockers like phenytoin, carbamazepine, or oxcarbazepine. Now, if it is a loss of function, then those medications should be avoided because your channel is not working well already and you use a channel blocker, the cell will suffer much more. So that's why we say in Dravet, which is a loss of function, you should avoid sodium channel inhibitors, and the best drugs are valproate, clobazam, stiripentol, fenfluramine, and CBD. SCN2A can also cause epileptic encephalopathy due to loss of function, although it's usually later onset compared to SCN2A gain of function. And again, in those cases, valproate, benzodiazepines, and levetiracetam are the best drugs. When you talk about potassium channels, those that are associated with DEE due to gain of function, we have KCNT1, and you might remember a few patients that responded extremely well to quinidine. That was not really consistent, and it in part might be because not all patients had gain of function. But even though some patients had very similar mutations, not all of them responded so well. But anyways, it's one possible treatment. Quinidine is a repurposed medicine, which is classically an antiarrhythmic drug, but can be used in this case. For KCNA2, acetazolamide or 4-aminopyridine are also options. For loss of function of KCN2 and Q3, carbamazepine, phenytoin, and retigabine, which was unfortunately removed from the market, but might be coming back specifically for certain channelopathies. And then we have the whole group of glutamate receptors. And again, if it is a gain of function, memantine, pradiprodil, and ketamine could be used. If it is a loss of function, then L-serine has shown some results. Finally, we should not forget dietary and a few other therapies. So for GLUT1 deficiency, which is a glucose transporter, ketogenic diet is the best treatment. For patients with P6-dependent epilepsy, and these are the genes that are associated with this condition, of course, pyridoxine is the best treatment. And for those with phenylketonuria, phenylalanine restriction is the best treatment. So to conclude, there are differences between somatic and germline mutations, and I hope that was clear and easy to understand. Differences between monogenic and polygenic epilepsies, and we are not yet testing for those with for polygenic epilepsies on a clinical basis. And then specifically for patients with DEE, remember that the phenotype can be caused by different genes. The same gene can cause different phenotypes. If the abnormality leads to a gain or loss of function, that might lead to different choice of treatment. And I will stop here, and I'll be happy to take any questions by email or live later. Thank you.
Thank you, Dr. Andrade. This is a great set of talks. So if you have any questions for Dr. Andrade, put them in Q&A session.
Hi again, I'm Danielle Andrade, and I'm happy to be here. I'll be talking to you about Dravet syndrome. So here are my disclosures, and here's a brief outline. So when we talk about presentation and management of Dravet syndrome, we have to remember that most of the information we have is in children, and we know very little about that in adults. So for every 7 papers published in children with Dravet syndrome, there's only 1 paper about adults with Dravet syndrome. But I'll try my best to go over the entire age range for this disease. So the early years of patients with Dravet syndrome. So these patients usually have a normal development until shortly after the seizure start. Usually they start with prolonged febrile seizures that can be either generalized tonic-clonic or hemiclonic between the ages of 5 and 15 months. They are mostly normal in between seizures initially. Then they start having afebrile seizures. And again, they can have several types of seizures, like tonic-clonic, atypical absences, focal seizures, or multifocal myoclonic seizures, which is a hallmark of this disease, of course. And unfortunately, the seizures tend to cluster, and they may go into status epilepticus very easily. Dravet syndrome has a high mortality, either due to SUDEP or to status epilepticus. The neurodevelopment stops after a while or starts to slow down. And when these patients become adults, they have usually a moderate to severe intellectual disability. Rarely we see regression, although it might happen after bout of status epilepticus. In adults, we see that they tend to have less seizures than children. So the period of very active seizures can end at different ages in different patients, but usually they start to decrease in frequency after the age of 13 years. Myoclonic seizures and the atypical absence seizures tend to decrease or even disappear in adults with Dravet syndrome. So if the diagnosis was not made in childhood, and you don't have the patient's records from the pediatric center, you might miss that they had myoclonic and atypical absences, and that might make the diagnosis much more challenging. Many adults with Dravet syndrome will be less sensitive to fever, but they can still have fever-induced seizures, and not only fever-induced, but hyperthermia-induced seizures. Most adults will have convulsive seizures that are restricted to sleep. And finally, the episodes of clusters and status epilepticus are less common in adulthood. These patients also have other comorbidities, and it's important because as a developmental and epileptic encephalopathy, we have to remember they have many different comorbidities. So as I said before, the development is normal until shortly after the seizures start, and then it tends to plateau. And as I said before, rarely regression. They tend to have ADHD and autism. Their gait can be very ataxic or crouch. As adults, the learning disability evolves to a moderate or severe intellectual disability. They have several gait problems. They have Parkinsonian features, autism, and they can be very compromised. In terms of management, here I have seizure management in adults, but it would be the same for children, of course. So the main goal is to maximize quality of life and decrease the side effects of medication. The control of convulsive seizures should be prioritized for their greater impact in the quality of life and the higher association with SUDEP. This diagram is the result of international consensus led by Dr. Elaine Wirral And it was agreed that the first choice of medication was valproate. Second would be fenfluramine, stripentol, or clobazam, and most of the time seizures would require more than one drug to come under control. Third line treatment would be pharmaceutical grade CBD. And then fourth would be topiramate and or ketogenic diet. And other things like levetiracetam, etc., would be after topiramate and keto diet. Now, it's important to remember that over 90%, between 80 and 90% of patients with Dravet syndrome, they have a loss of function mutation in the SCN1A gene, so a sodium channel. So one of the two copies of their sodium channel is not working well. And if they have less well-functioning sodium channel, you don't want to block the little bit that they have with drugs like carbamazepine, oxcarbazepine, lamotrigine, and phenytoin. There's an asterisk in phenytoin, and that's because it can actually be used in emergencies. We'll go to that a little bit later. If you have an adult who never tried stripentol before and is on valproic acid or valproate, you should be slightly more careful. So these patients may develop hyperammonemia, which, by the way, can be managed with carnitine in some cases. And the dose for adults is usually half of that for children on stripentol. And remember, you have to cut down on the valproate and possibly the clobazam as well. The other thing is fenfluramine, which is an excellent drug, have some common side effects like loss of appetite and weight loss and sedation. But fortunately, none of disease was seen in the younger cohorts. In the older cohorts, we don't have enough data yet. But patients that are on fenfluramine are required to have echocardiograms every 6 months. And just to clarify, remember that fenfluramine was a drug used in the 70s as a weight loss drug, but was removed from the market because it led to cardiac valve dysfunction in several patients. Now, the dose used for weight loss was much higher than the dose used for seizure control in patients with epilepsy. Another thing to remember is that stripentol can increase serum levels of CBD, clobazam, and valproate and fenfluramine, so you have to manage those as well. In terms of diet, kids usually can tolerate the ketogenic diet. Most adults will have to go on the modified Atkins diet. One of the reasons is just we don't have enough ketogenic diet clinics in the adult system, but it also might be a little more difficult to follow that in adults. Remember to ask about catamenial seizures. So patients with DEEs, including Dravet syndrome, can have catamenial seizures, and you might think of either adding acetazolamide or sometimes hormone therapy, or just giving some extra clobazam around their period or around the ovulation whenever the seizure frequency increases. And finally, remember that all these patients are at high risk for SUDEP, so we try to get the best possible seizure control. They are not surgical candidates, unfortunately. There are several reports of patients with Dravet syndrome that had surgery either because they had classic mesial temporal lobe sclerosis or some areas of focal cortical dysplasia, but if the phenotype was that of mainly of Dravet syndrome, the outcome was very poor. Status epilepticus, that is something very common in patients with Dravet, and every single patient should have a seizure emergency protocol that clearly states what the patient or the caregivers have to do at home and when they have to call the ambulance or take the patient to the hospital. So again, based on the consensus written by Dr. Wirral, after patient fails the 2 doses of a benzodiazepine at home, you should think of IV valproic acid load, assuming the person is not already on valproic acid maintenance with good levels. IV levetiracetam load, again, assuming the patient is not already on a good level of levetiracetam, and IV phenytoin or fosphenytoin load. And remember, we had the asterisks in the previous slides, and the reason is because it is not really contraindicated when used as an acute treatment for prolonged seizures or status epilepticus. There's not enough research to say that it is detrimental. We know it can stop seizures, so it might be used if needed. Next step is IV midazolam and finally IV phenobarb load. Other comorbidities, so of course intellectual disability. So like I said, patients start to show some developmental delay after the seizures start. And then they plateau, and when they become adults, you see a clear difference between their normotypical peers. Attention problems are not uncommon and might need treatment with psychostimulants. Autistic manifestations is also very common. Insomnia is another very common problem. And Parkinsonism is something that we see a lot in adult patients, and that is characterized by bradykinesia, antecholis, postural instability, and speech dysfunction. We don't see the tremor of Parkinson's disease. This is probably not a true Parkinson's disease, it's a Parkinsonism. Carbidopa, levodopa might help with the bradykinesia and the postural instability and the gait problems. Speech therapy may help with the speech dysfunction. And the other problems that we see are ataxia, crouch gait, and the Parkinsonian gait that might be helped by physiotherapy or carbidopa, levodopa. So in terms of motor manifestations, we see the crouch, the stonic, unblocked turns, wide base, small steps, speech problems, very classic signs of Parkinsonism. You see here the antecholis. We start to see that already, and it tends to get worse as patients get older. Here is the crouch gait, and you can see that the patient walks with his knees flexed and hips flexed. The patient may even be able to run, but has a very abnormal gait. Patient can also be ataxic, like this one, with a wide leaning forward posture with the chin to the chest. Very slow, unblocked turn, which is a Parkinsonian feature as well. So it's a mixture of several things. Or someone with a more classic Parkinsonian gait with small steps, no arm swing, and again the knee to the chest, the chin to the chest. And this is a study we did during the pandemic, and we saw that gait was worse in older patients. But an important thing is we saw our patients in the hospital while we still could, and we could not bring patients for the normal controls. So we had to rely on historical controls. And what happened is that our 31-year-old Dravet patients did much worse than the 62-year-old controls. So our adult, young adult with Dravet have a gait that is much worse than 62-year-old normal controls. The next thing I want to bring up is the fact that patients with Dravet syndrome should be given vaccines with careful monitoring. We know that many patients with Dravet had their first seizure after a vaccination, so parents might be reluctant to vaccinate them again. But we know that even though the vaccine might be a trigger for seizures, it's not the cause. This is not a vaccination encephalopathy, as has been clearly shown before. So the vaccine might be a trigger. So it is important to monitor this patient, consider prophylactic antipyretics and sometimes even benzodiazepines. I know of some physicians that like to give benzos as well as antipyretics around the time of the vaccine. But it's important, especially for those patients that live in crowded areas like group homes and things like that. So, and these are the vaccines that we should consider for these patients. So to conclude, seizures may become easier to control in adults. However, there are several other comorbidities that decrease their quality of life. We need to ask about sleep, gait, and appetite. Often the families, the caregivers come to us with the very significant issue of seizures. And if we don't ask about the other things, they will never be addressed. Don't forget about vaccination, which is a very important component of health in this population. And if you have any questions, please feel free to email me. Thank you very much. See you soon.
All right. So the first question, Dr. Andrade, many of us live in low-resource countries. We don't know of any place to access genetic testing. How do we go about doing that?
Yeah, that is an important issue. There is a company in the US who offers free genetic testing for patients with DEEs. I think they have an age limit of 5 years. And I believe if you have a connection with them, it's Invite, it might be possible to get free testing for your patients. I believe Dr. Tapper has arranged something like that in her country, so that would be one possibility. Of course, the other possibility is if you know any investigator who is interested in understanding the genetics of patients with epilepsies, and they can do that for you. Usually what they will ask you in return is a detailed phenotype of this patient. So they want to know in detail how the disease presented, how they responded to medications, et cetera, et cetera. I don't know that this is something easily reachable, but we could perhaps consider a way of connecting those investigators with interested physicians in the Caribbean. Something we can talk about.
Yeah, I think we have this global collaboration database. Perhaps we can set up a collaboration for genetic epilepsies using the global database. So this next question is, what's your recommended treatment for progressive myoclonic epilepsies?
Okay, so progressive myoclonic epilepsies, unfortunately, are very severe disease that tend to sometimes present in early childhood, sometimes later in adolescence. They might, if it is an adolescent, it might present as a juvenile myoclonic epilepsy because it's a patient with generalized tonic-clonic seizures and myoclones, but things tend to get worse with time. The basic rules are avoid phenytoin, and if there is any reason to think it's caused by a mitochondrial disorder, avoid valproate. So when would you know it is a mitochondrial disorder? If there is a history of mitochondrial symptoms on the mother side of the family, because these come from the mother. So hearing loss, cardiac arrhythmias, exercise intolerance, and things like that. Usually, levetiracetam is a good medication for myoclonus. We might need to increase doses over time. Of course, there are certain side effects that might be difficult to tolerate. Clonazepam is another medication that is good for myoclonus. The seizures might be controlled with medications but many of our wide spectrum medications, but sometimes it's the myoclonus that really gets difficult to control. So if you're not talking about Laforest disease, where you have all kinds of seizures and it's fatal in about 10 to 15 years from onset, you could, if it's one of the other ones, levetiracetam and clonazepam can help control the seizures and the myoclonus for a good period of time. Ketogenic diet is something that is helpful in mitochondrial disorders, as well as Laforest disease, might be helpful for other forms of progressive myoclonus epilepsies as well. And some of the very rare PMEs might have gene treatments. So if you have a patient with one of those, would be important to try and locate in something that might maybe we can help with as well. Investigators that have developed drugs, for instance, for Laforest disease. And so these patients can be enrolled in these trials.
So, one more question. Does improved seizure control in Dravet syndrome translate to better neurodevelopmental outcomes in adulthood?
That's an excellent question. I don't think we have an answer for that yet. It's traditionally, if you treat the seizures, some of the outcomes might be a bit better in general for the DEEs, but we cannot say that for sure yet.
One last question, and quickly, can CBD be used in any seizure type, and can it be used in drug combinations?
So yes, for drug combinations, but you might need to reduce the dose of clobazam and sometimes valproic acid as well. And in terms of types of seizures, it has been shown to be effective for convulsive seizures. For the non-convulsive seizures, for the absences and the myoclonic, there's not enough data.
All right. Thank you. Thank you so much. And let me introduce the next speaker, Dr. Gagandeep Singh. He's coming all the way from Ludhiana, India. He's the professor and head of the Department of Neurology at Dayanand Medical College in Ludhiana, India. He's also an honorary associate professor in Department of Clinical and Experimental Epilepsy at University College London, Institute of Neurology, Queen Square, London. He's the secretary of Institutional Ethics Committee at Dayanand Medical College. He's member of the Budget Review Committee of International League Against Epilepsy, chairperson of the Primary Care Task Force of the International League Against Epilepsy, and he's the Secretary General of Indian Epilepsy Association. So Dr. Gagandeep Singh will speak about care pathways and referral.
Good morning, good afternoon, and good evening.
It's such a great pleasure to be on this International League Against Epilepsy Small Islands web conference, and I'm extremely grateful to the organizers to have me on board. They asked me to speak on epilepsy care pathways in context of the small islands, and which I would be talking about in the next 20 minutes or so. So, ladies and gentlemen, from the Caribbean, let us go to Malawi in Africa, where we have Dr. Watts, who is an Irish woman, a Christian missionary, and someone who came into Malawi to help the people of Malawi. And she wrote about epilepsy and the kind of care for epilepsy in the British Medical Journal in 1989. Quote unquote, in Malawi, people with epilepsy spend much time and money traveling from one traditional healer to another in search of help. And they use various kinds of treatments, including roots to induce purging and vomiting. And the roots are also used in the water for bathing. And mind you, the bathing is not done at the usual place, but in a rubbish pit, just to emphasize the kind of stigma and discrimination that's prevalent in Malawi in relationship to epilepsy. And when she set up an epilepsy clinic in her Christian mission hospital, she noted that attempts to publicize by word of mouth were at first not very fruitful. And indeed, there were very few patients in her epilepsy clinic in the first few months. And then the numbers tipped and started increasing, as you can see in this graph. What was the secret of her success? Well, they're listed out here in this slide. She publicized the availability of treatment. She educated the patients and the staff, very important. She used a simple regime comprising of phenobarbital, ensured that there was an adequate supply of drugs which were provided free of cost. There were monthly review clinics, and she ensured that the patient always sees the same healthcare worker. Ladies and gentlemen, coming back to the Caribbean, and we know that Caribbean islands have a significant population, something like about 44 million, and therefore we could expect at least about 200,000 people with epilepsy in these islands. And this is the state of care for epilepsy as depicted in the PAHO WHO report on epilepsy, published in 2013. A little old, but it's really very telling. Look at the number of neurologists, very few in 2013. I'm sure it would have improved by now. And look at this table which depicts, excuse me, look at this table which depicts the availability of diagnostic facilities for epilepsy in the Caribbean islands. Really, really dismal. And if you look at this very important and interesting paper published in 2015, again, the small number of neurologists in the Caribbean. The anti-seizure medications are, of course, available. And the authors very interestingly ranked the barriers or the obstacles in care provision for epilepsy. And most respondents felt that the lack of specialists and the lack of diagnostic equipment were the two most important barriers for appropriate and adequate care provision for epilepsy in the Caribbean islands. There were other, of course, barriers, for instance, financial barriers, long wait times, access to anti-seizure medications, socio-cultural issues, geographical barriers. But the two most important were the lack of epilepsy specialists and the lack of equipment. And we need to interpret this in a larger context. And we know that and this is from the WHO Atlas of Country Resources 2017, the disparity between different regions of the world, where Europe has 9 neurologists per 100,000 population, as opposed to many other areas, and the Caribbean, where the number is less than 1 per 100,000, right? And the disparity is also there between the cities and the villages. And whereas the capital city of most countries would have a good number of neurologists, there would also be a reasonable number of neurologists in the larger cities, but the smaller cities and the villages would not have any neurologists. And this is across the world. The WHO has also laid down the levels of care for people with epilepsy, and world over, the point of first contact for people with epilepsy often is the primary care physician. And in some countries, the primary care physician is the only contact. And in many countries, particularly in low-income countries, the first point of contact is not a physician, but a nurse, right? And then, you know, these people with epilepsy might be referred, and the indications for referral might be varied to level 2 care, usually a neurologist. And then if seizures are not controlled, for instance, drug-resistant epilepsy, to a comprehensive epilepsy center where there are a number of pharmacological options, as also a number of non-pharmacological options like surgery, diet, neuromodulation, and so on. But this chart is extremely, extremely telling. It tells a lot because it tells us two things. One is it emphasizes the treatment of comorbidities. And the treatment of comorbidities spans across all 3 levels. It's not restricted to level 3. Treatment of comorbidities, the recognition and treatment of comorbidities is important at level 1 and level 2. As also scaling up the awareness of epilepsy, its causes and consequences, and social education about epilepsy also spans across all levels of care. Ladies and gentlemen, the universe of people with epilepsy includes a lot many people. It's not just the neurologist or the epileptologist, but community health workers can play a huge role, and community health workers can go home to home. They can monitor adherence, they can help in improving adherence, help in improving self-management, they can help in mitigating stigma associated with epilepsy. So they can actually do a lot. And then there are advocate social workers. In different countries, people with epilepsy might be seen by internists, pediatricians, psychiatrists. And of course, there are a whole lot of advanced care specialists, including nuclear medicines, neurosurgeons who do epilepsy surgery, psychologists who are involved in pre-surgical workup, who are all associated with care for people with epilepsy. Ladies and gentlemen, there are many papers like this, and most of these papers are from high-income countries, and there is little doubt that treatment of epilepsy by a specialist can improve a lot many epilepsy outcomes. And this is just one paper where the specialist care was for epilepsy was associated with a reduction in premature mortality. But there are many other epilepsy outcomes which are improved by specialist care. But what do we do in regions and countries where specialist care is not available? So we come to primary care. And the World Health Organization, especially in a number of its announcements and declarations, have emphasized the importance of primary care for epilepsy, especially in situations where specialist care is not available. So why epilepsy? Because it's easily treatable. You start someone with epilepsy on an anti-seizure medication, simple and regime. there is a 70% chance that his seizures would be controlled. We know that there is a wide treatment gap, more than 50% in the Caribbeans, often hitting 80 to 90% in many countries, many low-income countries. We also know that epilepsy is associated with increased premature mortality, about 2 to 3 times the mortality seen in the general population. And treatment can reduce some of the premature mortality associated with epilepsy. And not in the least, there are immense psychosocial consequences of epilepsy, the stigma, the discrimination, which are indeed difficult to measure. And why primary care for epilepsy? We know that primary care brings treatment closer to home. It's quicker, it is more cost efficient. It can be integrated into a complete healthcare package with emphasis on prevention. And mind you, prevention is very important because there is a huge preventable burden of epilepsy, roughly about 25%, comprising of stroke, traumatic brain injury, perinatal events, and CNS infections, all of which are amenable to primary prevention. In our country, in India, we did this trial, which was a community-based cluster randomized trial, where we randomized these clusters into usual clinic-based care or home-based care, where community health workers provided medicines, monitored adherence, did counseling for stigma and self-management, and were followed up for 24 months. And you can see the difference in outcomes. The home-based care with community health workers had experienced better adherence rates, and towards the end of the trial, better seizure outcomes. You can see it, these graphs speak for themselves. Right. So the International League Against Epilepsy was cognizant about the important role that primary care health workers play in the epilepsy care pathway. And in 2019, commissioned a task force to design an epilepsy curriculum for primary care health workers. And over a year or so, the task force went through a series of steps, including assessment of the needs for primary care providers, identification of core competencies, elucidation of the learning objectives, and then the curriculum was circulated worldwide electronically, and a global feedback was accrued, which led to revision and refinement of the curriculum. And the end result was an evidence-based and consensus-driven primary care epilepsy curriculum. So the curriculum is divided into 6 domains. There are 26 competencies and 85 learning objectives. It might seem a little daunting, but ladies and gentlemen, these 85 learning objectives are actually constitute the body of knowledge that is essential for management of epilepsy in the primary care. So this is just one of the domains. I think the management of status epilepticus, one of the most serious expressions of epilepsy, is extremely. And in small islands, these patients cannot be transferred overseas. Time is of essence. Losing time, you can lose a lot in terms of outcomes. And if you look at delays in the management of status epilepticus, there can be delays in recognition. For instance, people might not know that they're in status. There could be delays in reaching or accessing care, and these could be geographical barriers, distance, for instance, socio-cultural barriers, financial barriers, and so on and so forth. And there might be delays in care provision. We know that there should be protocols in every hospital for management of status epilepticus. So there might not be a protocol, or the treating physician in the emergency might not be aware of what the protocol is. There might be a lack of intensive care beds or neuromonitoring equipment, and so on. I think emergency care for status epilepticus is something which is entirely in the primary care domain, especially in the small islands. Referral is also extremely important in the primary care epilepsy curriculum. And it's important to know when to refer. Not only is it important to know when to refer, but it is also important to know how quickly to refer the individual with epilepsy. And that communication of the referral is extremely important, both to the referred doctor, as well as to the specialist, as well as to the patient. Why is he being referred? What is the reason for referral? So that is something that is extremely important and is recognized to be extremely important in the ILAE primary care epilepsy curriculum. The indications for referral might actually vary according to the country and the region. For instance, in many countries like the United Kingdom, every patient with epilepsy is referred to the specialist for making and confirming a diagnosis of epilepsy and drawing up an initial treatment plan. But this might not be possible in every setting, and especially where there is a scarcity of specialists. And then there are a variety of indications, and this again might be varying, including people with functional dissociative seizures, pregnancy in women with epilepsy, special population, comorbidities, and then of course the failure to control epilepsy leading on to drug-resistant epilepsy. Knowing very well, the earlier these people are referred for pre-surgical evaluation, the chances of adverse outcomes are reduced, right? So policy is extremely important, and just a slide on how important policy is. And there are some very good examples of how policy can influence the epilepsy care pathways. And for instance, in Chile, policy mandates that every adult with epilepsy should have at least one visit to a neurologist in a year. And for children, it is 2 visits and 2 nurse visits per year. In UK, for instance, there is a NICE guideline which dictate clinical practice. And in China, the Chinese League Against Epilepsy formulated epilepsy guidelines first in 2007 and then in 2015. And these were adopted and endorsed by the Ministry of Health. I just love this paper. And this is from the Caribbean. And with new technology available, a number of apps, teleconsultations, I think digital technology is playing a huge role and bridging some of the huge gaps in epilepsy care, not only in the small islands, but across the world. Ladies and gentlemen, in conclusion, this is my personal philosophy. It might be a little provocative, but I strongly believe this. In situations, quote unquote, in situations where seizures have recurred or are likely to recur, it is imperative to start the most appropriate, available, and affordable anti-seizure medication, rather than to wait for investigation or specialist. Now, people who do not agree with this, experts who do not agree with this might say that, well, it's always better to refer the patient to a specialist and then see whether he really has epilepsy and then make an appropriate plan of treatment. But particularly in situations where it is difficult to access specialist care, I think it is more important that we should start the treatment as early as possible in situations where the risk of recurrent seizures is high, and we should not wait for investigations in such situations, right? So yes, this can be a little provocative, and as also this commentary that we recently wrote, this is just fresh from the oven, the case for levetiracetam to be included in the essential medicine list. And we wrote this because India was one of the first countries to introduce levetiracetam on the essential medicine list. And this, we think, is a very welcome step. And this is particularly so because of the characteristics of levetiracetam, which make it a very appealing drug to use. The ease of use, we call it the ease of use. It's a broad spectrum drug across many different types of seizures. It has very good pharmacokinetics, very less protein bound. It is does not have drug interactions. It is really not significantly teratogenic when used in women with epilepsy. So it has a number of advantages. And I think if treatment has to be instituted in this kind of setting, levetiracetam is a very, very good drug. However, I think the catch is that that the drug should be available and it should be affordable. So provided it is affordable, it is available, I think levetiracetam is a very good option. Ladies and gentlemen, I think there are wide amount of disparities in the small islands alone, and therefore it's difficult to have one model for care. And I think that no one size fits all. Thank you so much. Such a great pleasure to be here on this meeting. Thank you.
Thank you. So, Gagandeep, you're here, and there's I think Judy is still here, and Dave Clark is here, and I'll encourage the audience to ask questions, but let me get started because you brought up some really excellent points. You said community health workers provided an outcome which seemed to be better in your study with that Sanders study you showed than waiting for specialists. I can tell you that in one of the richest states in America, California is now going to community health workers to address healthcare disparities. We'll never have enough doctors, even in California, which is very rich, to take care of everyone. So is your curriculum going to be, do you think there'll be a separate curriculum for community health workers? How do we reach them?
So I think that's very relevant, and one of the, within every healthcare system, the roles and responsibilities should be clearly charted out. And then if you think of community health workers, how they can be engaged in epilepsy care, I think, if they go home to home, they can address stigma, they can address adherence, monitor adherence, as well as, just to make sure that people are taking medicines, emphasize the importance of adherence. So and then self-management. What to do if someone has a seizure, what's the first aid? And so these are some kind of educational activities which are really, really crucial and indispensable for optimal epilepsy care. And I think community health workers can really play a big role, and they would actually spare specialists and doctors a lot of time and effort which can be directed elsewhere. So I think this is they can play a huge role, and if we have a curriculum which is specifically oriented to community health workers, it should emphasize these educational points, that is self-management, stigma management, and then adherence, emphasizing the importance of adherence. Of course, we do not expect them to prescribe, we don't expect them to do the other bits, but these are some things which would form the basis of the community health workers curriculum. At present, the primary care is very generic, but I think if we were to do something specifically for community health workers, these are the things that need to be included. But again, as I said, there are wide variations in practice, wide variations in how things are done in different countries. So we need to keep that in mind.
So there's a question. Go ahead, Dave, you came on.
No, I was just going to totally agree with Gagandeep. just give hats off to the pediatric group, at least through the Caribbean island networks. I think that branching tree that you spoke of is the way to go, because although many islands may not have neurologists, the fact that they meet so often and engage with other neurologists is key. That's it.
Yeah, I think interaction is, we need to have a lot of interaction, and these, interaction is the key. So specialists should interact with primary care physicians, they should interact with internists. It's a two-way process, and I think it's a win-win situation for everyone.
I have a question in the box about comorbidities. You brought up treating comorbidities. How do you approach treatment of comorbidities by primary care physicians or general neurologists?
So I think, particularly when we talk of mental health comorbidities and psychiatric comorbidities, so the MH, the World Health Organization has the MH gap, and the MH gap, the emphasis is for primary care providers to recognize and treat mental health conditions. So there is a huge emphasis. Epilepsy is also part of the MH gap program. And therefore, when we have primary care providers, and mind you, in many low-income countries, primary care people are the only ones who can actually see epilepsy, and because there are no specialists. So they are the only point of contact for people with epilepsy. So I think in the given situation, when there is so much of emphasis for primary care physicians and primary care providers, it might just be a nurse in some of the primary. The first point of contact is just a nurse. And the WHO expects and advocates that these people should be able to recognize and treat mental health conditions. So they should be also, I guess, be able to recognize and treat psychiatric comorbidities associated with epilepsy. So that's the point. I mean, it's not that someone has psychiatric comorbidities, they have to be referred to mental health. Of course, if there's a mental health specialist, sure enough. I mean, that's the way to go ahead. But in places where there are no psychiatrists, there are no epilepsy specialists, I think the onus actually falls on the primary care people.
I have another question about access to anti-seizure medications. Many hospitals face challenges. You referred to the essential medication list, the fact that lab should be there, but what other things can centers do, governments, to improve access to ASMs?
I think that is, you've touched a very, very important point, and that is the key. And we have this project running and in 3 Indian districts, and we did not many interviews with primary care providers in the primary healthcare centers in India, and we just asked them, why do people with epilepsy not come to primary healthcare centers? And one of the major reasons which all kinds of stakeholders said is the medicines are not available. So if the medicines are not available, then they will not come there. I mean, that's extreme. So I think access to medicines is, access to quality care medicines is, quality medicines is extremely important. And therefore, I think this is probably the key to good quality epilepsy care, making medicines available, whatever is there. And in many countries, phenobarbital is the only anti-seizure medication. So I think that is something that we really need to work very closely with policymakers, administrators, whatever, whosoever. As specialists, we need to emphasize that medicines should be continuously available. We know that there are people with epilepsy who miss even a single dose of medicine, they can have seizures. Not all, but I mean, they can have seizures. So how important is access, continuous access to medicines? I think that just needs to be emphasized again, time and again.
All right. Thank you. I want to thank you and all the presenters today. I want to thank all the participants who participated. We had amazing number of people present for our sessions today. Please fill out your evaluation form. We really would love to get feedback and find out how we can do this better. And again, complete the survey for your certificate. We have a certificate ready for you. So please go ahead and complete your survey, get your certificate. And Gus or Jessica, if you have any other announcements, otherwise we can close it out.
No, that's everything. Thank you very much.
Thank you. Thanks a lot, both of you, for organizing and keeping us on time, Gus and Jessica. Thank you both.